So first, let me introduce the two eminent international faculty. And we are having Dr. Ciro Andolfi. He is a pediatric urologist from Hospital Mary Infant Pasteur. And this is located in Colmar, France. And he obtained his pediatric urology training from Chicago Medical Center. And he has a special interest in minimally invasive surgery, especially robotics. And he holds numerous publications as well as enjoys many important editorial positions in many reputed international journals. We also have Dr. Pankaj Dangle. It is really nostalgic to have him back in Mumbai these days. He must be celebrating his vacations here. And Dr. Pankaj is currently positioned as Associate Professor of Urology in the Department of Riley Children Hospital at Indianapolis. And he is basically an alumni of Lokmanya Tilak Municipal Medical College, Mumbai. And he has his residency from University of Chicago. And he had his fellowship in pediatric urology and from Pittsburgh. He has many recognition and awards in his account. He has numerous publications and holds many eminent editorial positions in various journals of international repute. And he has a special interest in urolithiasis, and he has many research publications in this, along with some interest in reconstructions. So we welcome both Dr. Ciro and Dr. Pankaj to our first clinical ground round for pediatric section of Urological Society of India. So now the stage is open to have some words from Dr. Amilal Bhatt.
But yes.
Bhatt, sir?
Mute, I'll open it up.
Please unmute, please unmute.
Yeah. Good evening to everybody. I welcome you all for this grand round of pediatric urology. And this is the first attempt of its own kind. And all efforts has been made by Dr. Ansari and his team. And we have special experts of Ciro and Dr. Pankaj, who are expert, and many other people will be joining. And I think it will be a very useful starting from the residents to the consultants, and may be that this will be helpful in their changing their practice. With these, I thank you all, and now you can start, Professor Ansari.
Thank you so much, sir. So our scientific session starts with part 1, that is history and examination for the case of non-palpable testis. And the national experts for this section is Professor Amilal Bhatt, Professor Chandra Singh, and Dr. Malika Arjun Reddy. We are ready, sir?
Yes, I think we should start.
And the case presenter will be Dr. Anil Bed.
Good evening, sir. Yes, sir. Good evening. Yes, sir. Good evening, sir. I'm there, sir. Yes.
So this is the story of the child who is a 2-year-old male, and parents came to us with empty left hemiscrotum, and they could not find any gonad since birth. And as such, there is no history of any swelling or pain in the groin or scrotum. As well as there is no history of any lump anywhere else. Abdominal muscles are normal. There's no history of lower urinary tract symptoms, or there is no history of any other systemic complaints also. So these are the other clues that available for antenatal history and prenatal, and family history is not contributing. So this is the clinical picture.
Yes, sir.
Okay.
Sir.
Just look at this. We will ask what, Anna?
Yes.
We will give you the clinical examination finding. Left hemiscrotum is empty. There is no gonads or the vas palpable. With poorly formed left hemiscrotum. Right testis is palpable, which was 3 into 2 centimeter. Well formed in the right hemiscrotum. Vas was also separately palpable, and the stretched penile length was 5 centimeter. External urinary meatus was at the tip of the phallus. It was adequate. While on examination, perineal examination, normal with normal anogenital distance. So what would you like to ask more in perinatal history?
Sir, in the perinatal history, our concern is which dates back, is whether the child is a premature birth or is a child is low birth weight for gestational age. There are certain histories which can point out towards these findings, like whether the delivery was normal or it was by cesarean section. Is the patient child was born healthy with adequate weight? Was there any ICU stay in the hospital? How many days post delivery the admission for the mother? All these are histories which can point out towards this diagnosis, sir, in the perinatal part, sir.
Oh.
Yes.
Sir, expert, sir, would like to ask some more questions regarding this?
Dr. Anil, I would also include, this is Dr. Pankaj, I would also include in the perinatal history if the mother received a normal perinatal care. Did she receive multivitamins? Did she receive regular checkup? Because those things are important for not only the low birth weight as you talked about, but these are some of the clues that you would get from the history when you're asking something, when you're concerned about something which is embryological origin.
Yes, sir. And sir, also in Indian scenario, I would also like whether the delivery was an institutional delivery, because in certain remote places there can be a home delivery.
Correct. Another important point, the mother history, whether she took any estrogenic or progestonic drugs, and whether she was treated for fertility or not. These also should be asked in the perinatal.
Correct. Whether it was, as Dr. Bhatt said, natural.
Yes, sir. And also in terms of mother, that whether mother is had history of smoking or mother is a diabetic, and what was the maternal age of delivery, all factors which are important, and the birth of the child, whether it's a first birth or subsequent birth.
Okay, so Dr. Chiru would like to add anything to it?
Yes, I think one thing more, is a single child or with a twin?
Yeah. It is single child, sir.
A single child, okay. Or any congenital history, is the other brother or anybody in the family, they have any history of this similar problem of undescended testis?
As such, the parents did not give any history of this similar conditions in siblings.
Okay.
And also, because he's 2 years old, when he was an infant, whether he had any inguinal swelling, redness, which resolved on its own.
Yes.
Yes, sir. And also any history of having seen a descended testis in the past.
Oh yes. You asked about the any intervention in the past, because the kid is already 2 years old. If any manipulations, surgical manipulations has been done or not. Is that?
Yes, sir.
Okay. I think Dr. Mallikarjun is still trying to join. Yes, sir. So let us have what does literature support. So obviously you told about the premature birth and the low birth weight for gestational age. And So what is the relevance of this C-section in this history?
Sir, one relevance is if the patient has if the patient had C-section, then there is a possibility that there may be a preterm delivery, which it gives a pointer towards there has been certain problems. Maybe it basically goes towards indication that is a low birth weight delivery or not, because C-section will be done in a setup which is not in a normal setting. Like the C-section frequency is higher in maternal diabetic patient, in eclampsia patient. These were all pointing towards low birth weight. So that's why that's the history of intervention.
Okay, so these are some statistics which are related to that. In full terms, the incidence is low, and while in terms of preterm neonates, it may go even up to 45%. And
up to 28 weeks and 28 weeks, less than 28 weeks, the rates are quite high, Dr. Anil.
Yes, yes, absolutely, absolutely.
Yes.
So if you go weight-wise and lower the weight, higher the chances of prevalence of cryptorchidism. And if the weight is in the range of normal, as per the normal parameters of that country, the incident prevalence is only 3%. And this is an important study from Lancet, and I think this is from two countries, Nordic countries, Finland and Denmark, and have shown the distribution of this birth weight. If it is less than 1,000, this 1,000 grams, and the prevalence is almost 100% of this undescended testis. As the birth weight increases, the prevalence becomes low.
Is the weight chart is likely different for our Indian subcontinent? So it may be different figures for our Indian patients, where the incidence may be way higher for the same weight compared to the Danish. Because remember, Dr. Anil, these are tall people in Denmark. Our stature is very short, and our birth weights ideally are smaller in India. So this may not be true. So expect more incidence in India when you match the weight for our Indian patients.
Oh, absolutely.
Yes.
Yes, absolutely. Because the low birth weight is quite common, especially in the peripheral part of the Indian villages. And this undescended testis is quite common. That is different that most of the time, because of the observation, many of these may descend spontaneously. But obviously, as Dr. Pankaj highlighted, the prevalence has to be much higher as compared to the West. So, Dr. Chandra, Dr. Bhatt, Dr. Siro, any other point on this?
Yeah, just continuing in that, the distribution in this group, if you look at it, ours will peak around 2,500 to 3,000 grams. And the number will be much lesser in the weight above that.
Absolutely, absolutely, absolutely. So moving to the next question. Is it a heritable disease? And what would you like to ask in family history?
Sir,
that in mind.
Yes. Sir, I would like to ask if there is an incidence of undescended testes among the family members, because there is a relationship between the incidence among the family members and higher relative risk among the patients, especially from the paternal side. From the maternal side. When we review the AUA 2023 literature, they have said that there is some association, but the genomic loci may contribute, but the proof is not. The evidence is weak. But the incidence is more, especially if you see twin brothers, there is a very high incident relative risk ratio. Similarly, among the maternal side, there is an increased incidence than compared to the paternal side. Yes, sir.
Mm-hmm. So if there is a history of undescended testis in the father, what would be the chance the child having his first son having undescended testis?
Sir, there are various studies, but some are saying that if there is in father, then the child is having a 2.31 relative risk of having an undescended testis. Whereas certain studies which are saying it could be around 4 to 5, in the range of 4 to 5, around 4.5 having undescended testis. Like in Danish study, it is like 2.3, and similarly a study conducted in the Nordic country, it was said about to around 4 odd ratio. So this is what the relationship is. It's highest among the twin brothers, so around 10 times the relative risk.
You might want to also ask if there is any urological, any familiarity for any other urological malformation eventually. So they can
yes, sir. There is a yes, sir. There is also seen that increased incidence of undescended testis if there is a family history of some disease like inguinal hernia or hydrocele. In those patients with such family history, also incidence were high, but the proof is weak, sir, at the present.
I asked Anil, suppose he is the second child of the family. What is
Yes.
and first child also had undescended testis. Then what is the likelihood that the second baby will have undescended testis?
Sir, if it is around 0.5 is the relative risk, sir. If the first child is having then second child is having 3.5 times the relative risk.
This is the 5 times then.
3.5 times.
Okay.
But some are saying that in brothers there are 6 times. Like it ranges, I would say, range between 3 to 6 times the relative risk.
Suppose he was the product of this assisted reproductive technique, and two brothers were born together. What is the incidence then?
Sir, if there's a twins, then it is a 10.1 times relative risk ratio, sir.
And suppose if it was a male baby and another was female baby, then the risk remain the same.
Sir, sir, I'm not very sure, sir, but according to
same
siblings,
sexes,
it is like 3.3. Sir, I'm sorry, sir. Sorry, sir. It's a trick question. I'm sorry, sir.
Or Dr. Chanda, you helped him.
Okay. If the baby is twin and
Yes.
baby is female, so
Yes.
what are the chances of having other disease in female baby?
Sir, it's 0%, sir.
No, not UDT, but other.
Okay, sir.
What other problem a female child may have?
What Dr. Bhatt is asking is some of these urological anomalies can be associated, right?
Yes.
Yeah.
Yes, sir.
What could be? The female can have inguinal hernia.
Yes, sir. Yes, sir.
Do you know which side is more common?
Yes. Which one is
Dr.
more
Anil,
common?
which side is more common in females? Inguinal
Sir,
hernias.
left side, sir.
Yes.
So you just guessed it or it is you read it? Anil?
Yes, sir.
It is a guesswork?
No, sir.
Or it is a gut feeling?
No. No, sir. Sir, in male, it is like a right side mein palpable testes are more and non-palpable testes in the left side more. And I have also read somewhere, I was little doubtful, but I knew it's left side.
Okay. So as you rightly told, because most of these undescended testes, they are isolated. And still, there are many theories about this, which are multifactorial. Genetics may be one of them, familial, endocrine, and the environment may also be one of them, which we will be discussing in subsequent slides. And this is the study, I think, which you quoted from the Denmark, the risk among the first degree, the second degree brothers, our brothers, uncles, and the grandfather. Yes. If the same sex, the twin, it is almost 10 times relative risk. And among the brothers, is 3.5. Father with under history of undescended testis, this is 2.3. And in the brother and the uncles, this relative risk goes down. And the third degree, it is almost very low. So this is the another study from Denmark, and this is showing another. Yes, this the same paper is showing the another angle, whether if the risk come from the maternal side or the paternal relatives, and it's very interesting. They have shown if there is a history of undescended testes on the maternal side, the chances of undescended testes are more. Yes, see, while in the paternal relatives, the chances are less. So mother is having more influence if there is a history of undescended testes in the maternal relatives. It is less on the paternal relatives. Yes, this is the another study from Dr. Allard, and this is from Germany, and they have also highlighted among the brother the risk is nearly 7%, and in uncle this is 5.2. Father is 4.5. Yes. So any other input, Dr. Shiro, Dr. Pankaj on this, or should we move to the next question?
I think the Danish study is a good study to know the exact linkage of the genetics and the
Yes.
familial structure, how it links.
Yes.
It's way difficult to assess the same thing in Western culture because
Yes.
many times there is somewhat part consanguinity. There are half brothers, half sisters. It's difficult to guesstimate the exact odds ratio or the relative risk in families. In my practice, somehow I tend to find more uncles than the fathers who have had history of undescended testes.
You mean in Indiana, or it's because there is a higher? Is because there is a higher consanguinity in Indiana? Is that what you're saying?
I don't know. It's hard to pinpoint, but somehow it's when you keep digging and asking, then they keep thinking, oh yeah, my brother had an undescended testes. Yes, my father, mom's father had an undescended testes. So it's, as you said rightly, it's a mother which is predominating, not the father. And it's always that side, but it's difficult to kind of get the exact genetic linkage in families when there is so much goes on behind the scene that we don't know in terms of relationships of half brothers, half sisters, or brothers from different mothers or fathers. So it's, I don't know if we can do the same study in the US. Is what I was trying to allude. So the Danish study gives a nice kind of overarching mapping of the family natural history and the genetics association. And half the patients don't remember any of these, to be honest.
Right, absolutely. Because what you said, very interesting point. In your experience, this may be slightly more deviated towards uncles, because this is not only the genetics which is playing a role. Environmental factors, they also play an important role. Besides the other hormonal factors, or endocrine factors also. So maybe that genetics alone may not drive these lineages from one family to another. Environmental factor may also deviate from this purely to father or mother, rather going more towards this uncles also, what you find in your patients. Because this is not the only, genetics is not the only factor which is influencing this undescended testis.
Yeah, and We being the only pediatric group in the entire state, northeast of our state has more duplex anomalies, more hypospadias, more undescended testes as we go more towards Michigan side. So there is very interesting genetic kind of problems there in that part of the state.
Yes.
Another one parameter is when it comes to counseling them, when it comes to bilateral, parents are more keen to know what's the probability that the next child will develop. But the data in that is quite scant, unfortunately, when it comes to bilateral, which has adverse implications on fertility.
Right.
Correct. Yes. Yes.
Another important point, if anybody knows about the literature, the incidence is going higher in the marriages in the same caste. Means going one family with the same family and then marriages, and I think Pankaj may have some idea about that one. Another one is there is a different marriages, and that because genes patterns are goes in one family of like that one. So if that goes, there are more chances of all congenital anomalies. Is same related with this one undescended testis also?
Yes, Dr. But we see a lot of congenital problems in Caucasians, like undescended testes. We see more in white Caucasian patients compared to African Americans or Asians, or we have a lot of Burmese, we have a lot of Haitian, and we have a lot of Hispanic patients. Majority, I would say 80-85% is Caucasian patients.
That's what I wanted to know. That's good.
Okay, so we move, otherwise it will consume a lot of time, sir, because we move to the next question. What are the risk factors for undescended testes?
Sir, we have discussed a lot of risk factors. Since it can be in family, so there is one part that genetics can play a role, and then hormones are very important for the descent of the testes. So there are factors which are leading to hormonal exposure, or some hormonal diseases can lead to this, and also environmental factors, as we have known, the maternal smoking and diabetes. All these are also associated with the undescended testes. So I would say these are the risk factors which are being with the descended testes.
So these are the risk factors. So tell us something about the genetic susceptibility.
Sir, as we have come to conclusion that the incidence among families are higher, relative risks are higher. So when we analyze for the genetic susceptibility, there are two genes which has been positively proven have to have a role. That is insulin ligand 3 and also this LGR8 ligands. Two genes which have been proven that they have some positive role. Apart from that, there are certain things under evaluation like OXA gene or SF gene and some repeats. But the two conclusively proven are these, sir: insulin ligand 3 and LGR8.
So what happens to these genes?
Sir,
you are telling two genes, one in the insulin-like peptide and second G protein coupled receptor gene. Yes.
Yes. Sir.
What happens to these genes?
These genes are, sir, important because they are important for the important in the gubernaculum growth and bringing the testis down, especially in the transabdominal phase. Actually, in the transabdominal phase. So that's why the genes are important. Any malformation will lead to undescended testis.
So if yes, at any level, if the mutations are occurring, so they will this growth of this gubernaculum will be affected, which has an important part in the what you say is the inguinal scrotal phase of the testicular descent. Yes.
Yes, insulin ligand will be on transabdominal.
Okay. But another protein also said to be working on the gubernaculum also. Yes.
Yes. Sir.
So we move to the next one. What are the environmental risk factors? Because as we were discussing in the Danish study, there may be other hidden factors besides the genetics alone.
Sir, in environmental risk factors, there can be some environmental chemicals which can disrupt the normal descent of the testis, and there can be maternal exposures which can abruptly disrupt the descent. I will first say about the maternal is like there are incidences among the maternal smokers, maternal diabetic patients, which are having more incidence. And environment, there are certain chemical exposures which can lead to undescended testes, like polychlorinated biphenyls, phthalates, bisphenols. There are flame retardants and dioxins and pesticides. All these are there, sir, which influence the descent of the testis, negatively influence the descent of the testis, sir. And then maternal factors are also there. Then paternal factors are also there. They say some occupation like horticulture and farming occupation can lead to some minor contributions, sir. But yes, sir, these are the environmental factors which are associated, sir.
So these are the endocrine disrupting chemicals. And just to, because this is
Yes,
more
sir.
of theoretical, so these are the polychlorinated biphenyls, and they are basically used in the paper industry as well as the coolant, and they might affect. Currently, they have been banned, not used. Second is the dioxins. They are usually found in the atmosphere, and these are the persistent organic pollutants, and they are deposited in the fatty tissue. And more than 90% of the hormone exposure is through food, mainly meat and dairy products. Many national authorities have programs in place to monitor the food supply. Then coming to this phthalates are used in variety of household applications such as shower curtain, vinyl, upholstery, adhesives, floor tiles, food wrap, and the cleaning materials. They may also alter this endocrine pathway and result into the descended testis. And bisphenol, they are commonly used as plasticizers, and these are the plastic softeners. And plastic industry is very enormous worldwide, especially in developing countries. Everything right from water to tea is supplied in the polythene bags. So this is very commonly available in most of the food products here. So anything, Dr. Siru, Dr. Pankaj, Dr. Bhatt, Dr. Chandra, you want to add to these environmental factors?
Yeah, the thing is, in our country, unfortunately, we have a completely different set of chemical exposure because of unregulated factories, leather processing, paints. So the exposure of that has not been clearly studied, but we have a different spectrum of chemicals in addition to these established ones.
Yes, absolutely, absolutely. We do not have any control of it. Even the drinking water in most of the places in India is contaminated with all these pollutants. And there is no minimum or maximum limit for all of us.
Vegetables
for the young,
most of the
for the
vegetables
younger
and
generation,
fruits
the
are-
way I would put it is, the more and more we are advancing and more we are minimizing our efforts to do what we used to do 30-40 years ago with our hands. We are increasing the incidence of all the congenital problems, and it's to do with how we process our day-to-day life, be it plastic cups, plastic bottles, plastic containers. Ultra processed food is one of the biggest problems of the world right now.
Yes.
Obesity is on the rise, diabetes is on the rise, premature hypertension is on the rise. And if you put that into equation, into the maternal effects of the same, the fetus is going to sustain those effects. So whatever we are seeing, the increased incidence of undescended testes or hypospadias is all because what we have done to ourselves. So,
right.
And it's going to keep going up.
Yes. And I think this polychlorinated biphenyls, they are an important component of this fertilizers also. That is very commonly used. And Anil, did you tell something besides this? Did you tell something else about the environmental risk factor?
Sir, I said about the maternal risk factors like smoking, maternal smoking, then maternal diabetes, then paternal risk factor like paternal exposure to pesticides, like person working in horticulture industries. These are all I have added, and on top of this endocrine destabilizing chemical.
Yes, this is a one interesting study. This is a Department of Epidemiology from London University College, and what they have studied that there was a significant association with maternal smoking, and the odd risk, that is the cause and the occurrence, is significant. And this this forest chart is also showing the incidence of cryptorchidism. The mothers who have been smoking during pregnancy, the incidence of this undescended testis is higher, although the incidence of acid conditions like hypospadias was less. But as such, renal and urinary tract anomalies were also higher in these cases. And it was calculated that on the basis of many studies that maternal smoking causes 13% increased risk in of undescended testes. Although certain studies have shown that during pregnancy, if the mothers consume alcohol, there may be increased incidence of cryptorchidism, but it has been studied in meta-analysis that this has a very transient effect on undescended testes. Analgesics also have been quoted to have some risk on incidence of undescended testes. And as Dr. Bhatt initially said, that environmental estrogens, which this is not the regular medications, but environmental estrogens can also contribute to this, but there's no much literature to support it. And paternal occupation, horticulture is related to this, what we show the component of fertilizers.
Sir, I would like to just add a few points. In my analgesia, they have said the mechanism is like by inhibiting prostaglandins. Prostaglandins are necessary for the male development and leading to undescended testes. And that's just one point.
Just a quick question to Anil, to you. Does the diet has any impact on undescended testes? Vegetarian, non-vegetarian? Before we move to the next question.
Sir, this I can take reference from the previous slide.
Impact of diet.
Yes, sir. Non-vegetarian diet have increased incidence, sir. We have also seen that dioxins are there in the fat, sir. So
non-vegetarian diet, or it is the vegetarian diet which is more incidence.
Sir, I have taken this inference from the previous slide from dioxins, sir. You said that it is
but all inferences may not be appropriate to all the questions. So any vegetarian component which has been particularly studied in context of these undescended testes. Soya product, soya bean.
Yes, sir. Estrogens. Yes, sir.
Yes, isoflavones. They are the equivalent source of estrogens. That is why. But that has not been proven in large studies. But there are many studies which have shown that isoflavone might affect the descent of the testes. Okay, so we come to the most important question: how would you examine the child?
Sir.
What are the
at the beginning we will explain to yes, sir.
What are the different
at the beginning, sir, we will yes, sir. Sir, at the beginning we will inform the parents and the child who is the child regarding that we are about to palpate the gonads and the groin area of the patient. We will, if the child is very small, we will ask the parents to comfort the child for the examination. We will expose the child from the umbilicus to the below knee level, and the examination can be done. If it's a very small child, then it will be lying down cross-leg position. If the child is, or it can be done in the sitting cross-leg position, asking the parents to hold the baby on the lap, or in the adult child, it can be done in the sitting or a standing position. we will we will do the palpations. The gentle palpation will be done from the anterior superior iliac spine level over the inguinal canal, and from the opposite end we will do a counter palpation. In that we will try to evaluate the lowest point of the testicular lowest level of the testicular descent. After which, if we identify the testis, we will grab the testis, and from the dominant end, from the non-dominant end, we will try to push the testis towards the scrotum, sir. So this was I have taken this reference from I have read it in American Urology Association, sir. This is how they have explained to the examination.
So you rightly
And
said,
yes,
yes, sir. You have to explain the procedure to the parents, and there has to be calm and quiet atmosphere, warm and serene atmosphere, and use lubricant for the examiner's hand. There may be different positions of the postures you can examine, and the child should be calm. You should understand what is going to be done with the child. And this is the first is the supine position with the legs gently prolect here, where the scrotum is the entire perineum and both the inguinal sides are clearly visible. You can examine. How do we examine in the subsequent slide? And this is the upright cross-leg position, squatting, just like semi-squatting position. Both the scrotum is hanging down, and you can squeeze your finger like this and bring the testes down, or you may find the gonad anywhere there. And because you need you not only examine the inguinal areas, also scrotum, as well as you have to examine the femoral sides as well as perineal also for ectopic locations. So this is nice picture which Dr. Anvesa, our fellow, has provided. This is how you examine the child with undescended testis. Actually, this is a two-hand procedure, and one hand you have to keep on the anterior iliac spine, and you have to apply some lubricant, and you squeeze and you gently scroll your hand, right, starting from this anterior superior iliac spine along the inguinal ligament down to the scrotum. So if the testicular tissue is palpable, that may be felt, or if it is there, that can be swept down to the scrotum, especially in cases of retractile testis. So Dr. Siru, Dr. Pankaj, or Dr. Bhatt, Dr. Chandra, anything you want to add to this?
Probably you should also look for eventually an associated hernia, and then examine the entire body of the patient rather than just
Absolutely, absolutely.
I think along with that, not only hernia, hypospadias,
right.
And the important physical sign, these are, I think you should go and see through as the anorectal distance, which is that has been mentioned, that is important. Another important point is that many of the cases, especially of bilateral undescended testis or any hypospadias with undescended testis, see the bifurcation of the median raphe in the perineum.
So we will be coming to that, sir. So we will be coming to that. When to suspect that I have edited. Yes, yes.
Oh, edited.
Okay.
Yes.
Another one.
Yes,
Another
please.
one point I wanted to add. Dr. Pankaj is here. Says one interesting thing. Dr. Pankaj, you've seen India and Indianapolis. I've been Indianapolis. There, if you open a shelf, the shelf is filled with a whole bunch of toys for the children, yo-yos and other pull-along toys and everything. So the children eagerly go to the hospital knowing they'll get something. But in India, doctors are used as scarecrows. The moment you come inside, the baby starts crying. So one of the tips I follow is I have a bunch of balloons in my room. I give at least 2 or 3 to each child, and I have a box full of candies. Each one gets one so that they're comfortable, because most of our children are between 1 to 2 years. Once they're comfortable, it's much more easier to examine them.
Right. I absolutely agree. I was waiting for my turn to say that, as Dr. Singh mentioned, is once, Dr. Anil, once you talk to the parents, take your attention to the child, especially children who are 2 and above. They understand everything. Gain their confidence. Talk to them. Talk to them about what they do, what they like to play, what are their hobbies. Spend 2-3 minutes with them, gain their confidence. Imagine a 2-year-old or a 5-year-old and you attack their genitals. They are not going to cooperate with you. They're going to cringe. They're going to go into spasm, and your examination is not going to be easy. The second thing is just look at the scrotum, the symmetry of the scrotum. If this one side is hypoplastic, if the testis on the other side is descended, if it looks enlarged. Second thing, I have always seen there are subtle bulges in the superficial inguinal pouch that you can see on the side where the testis is undescended. That's a nice clue that there is a testicle there. And then gently just put your hand onto the patient and just roll your fingers as you're playing a piano. You will feel the testis 90% of the times. And if you don't feel that, then you start from the ACEs and then start going down. You will probably feel another 5% there. The rest 5% are either nubbin or they're undescended and interabdominal. This has helped me immensely over years, knowing how Dr. Singh mentioned is gaining the confidence of the patient, the baby. Even the baby is going to cry no matter what you touch. They know something is coming. Somebody is going to go give them a vaccine or something. So they're worried about a doctor in white coats. So it is very real.
I fully
Yes,
agree.
sir.
I fully agree. Yes, sir. And
In
because
this
we have
thing,
most of the time we have chai ki dukan in the hospitals, but we do not have confectioner shop in the hospitals because most of the hospitals are adult oriented, and because they're very pertinent questions because they keep babies and children engaged somewhere. Yes.
Yeah, I think
yes, sir.
as Professor Ansari has created in the ward like that during our conference time, like that and you see the child, they are so intelligent. Even a 6-month baby, 8-month baby, when the parents turns towards my hospital road, the road the child starts crying. They know, but it's so this is very, very important point, and we'll have to gain the confidence of the child. And second important point is that when we are many a time that gives help also. You see, when the child is crying, the intra-abdominal pressure increases, and you make a trick of that one, that have a soft finger and you palpate at that time. Many a time you will get the testis palpable in that situation.
Right, sir. Right. So
yes,
we move to the next question. Yes, Anil. Yes, quickly.
Yes, I was saying that in the clinical pictures which were shown, there was bulge seen at the superficial inguinal pouch. That sir was mentioned.
Right. So the next question to you is, what other associated features you would like to cover in your examination?
Yes, sir. Sir, many which we have already discussed.
Yes.
Sir, like we have to examine the scrotum. We have to examine. I have to examine the testis, how it is, the size, the firmness, and the position of the testis. Then we should also examine the contralateral testis. We should examine the scrotal area of the testis. We should see if there is an hypospadias. We should see if there are features of disorder of sexual development. We can also see if there are secondary sexual characters which are there. We should see the penile length, the associated hernias, and we should see the ectopic locations to see other positions where the undescended testes are present. We can see the anogenital, the ridge length. We should see the back and spine to see if there is features of meningomyelocele. All these things are important in the examination.
So just to recapitulate for the other PGs, because you have to see whatever on the epsilateral side, palpability, mobility, side shape and firmness also. As you rightly said, see the opposite side, scrotal evaluation, this size, rugosities, and hernia hydrocele. Very important point, penile length should also be mentioned because this is very important criteria to go for the next level of test. Hypospadias, any genital ambiguity, and anogenital distance, and of course if it is a grown-up child, because in India many children they present late even at the time of puberty, And even in adolescence, also in that case, you should look at the secondary sexual characters also. So besides this, what other things you will look into?
Sir, beside that, there are syndromic associations undescended testes also. So overall, with the appearance of the child, we get some idea about syndromic association. Syndrome child will be appearing like have a down. In the other syndromes, there will be like in the meningomyelin, we will see the bubble region, sir. In Klinefelter syndrome, we will see some features of Klinefelter syndrome: tall child, female obesity, and short neck, memory development. Secondary sexual characters, we have said that we should examine the secondary sexual characters, like in DSD with the 21 hydroxylase deficiency. It could be a female child with having some pubic hairs, which can give idea that it is not towards the undescended testis. So all these also are important part.
So you rightly mentioned, because these are some of the slides we recently in the I think this is the month of March, our genetic department they enjoyed the World Downs Day, Trisomy Day, and they had a get together of all the children with Trisomy 21, and I took one of the picture out of that. They have a large number of Down syndrome here, the genetic department, and other associated conditions may be neural tube defect, as you mentioned, and other syndromes like this Turner as well as this Klinefelter syndrome also. And there is a long list of the syndromes also. So you have to examine all this, like limb deformity, facial deformities, as well as the discrepancy of the limbs also, because this may be a part of various examinations of various syndromes also. So coming to the next question then for you, how do we differentiate between undescended testes and the ectopic testes? And what could be the different locations for ectopic testes?
Sir, undescended testes will be at the line of the normal descent of the testis. In ectopic testes, if the testis descending from the abdomen is present in the position which is not in the line of descent of the testis, we will say it's an ectopic testis. Sir. Different locations like away from the line of descent is from right from the above, like from pararenal position we say pararenal position, peripenile position. There can be superficial inguinal pouch, transverse ectopic testis, opposite side scrotum. It will be there. It can be in the perineal region. It can be in the femoral region, sir. These are the positions where ectopic testis needs to be palpated.
Which one is the most common?
Yes, sir. It's in the superficial inguinal pouch, sir.
Yes, absolutely. These are some of the differences between the two conditions. And just for the participants, for undescended testes, these are some characteristics. Testes are arrested in the normal path of descent, while it deviates from the normal path of descent. And testis usually dysgenetic, while testis is normally developed. It is not. The germ cells are not affected. Scrotum not developed on the ipsilateral side, but surprisingly, the scrotum fully developed but empty. Length of spermatic cord may be short, but length of spermatic cord usually long. There is a poor spermatogenesis because the spermatogonia are affected, but spermatogenesis is unaffected. In here, it can be associated with inguinal hernia. This is not associated with inguinal hernia. And the complications like malignancy, torsion, infertility are there with the undescended testes, while this testis is absolutely safe from malignancy or infertility, and there are very less chances going to torsion or injury. So I think if want to add anything, experts?
Dr. Anil, do you know why the ectopic testes happen?
Sir, one is if there is a weak gubernaculum, and one I have heard that there is a Lockwoods, the ligaments of Lockwoods, which are giving the pull of the testis toward the different positions. Sir, I'm not very sure, sir. My answer is not confident in this question. Sir.
So, do you know what a gubernaculum means? Gubernaculum means a rudder.
Yes.
A rudder of a boat. So if that gets misdirected by any of the above factors that we talked, it's going to get lost into the wrong position. What's the incidence, rough incidence of ectopic testis?
Sir, not 10-20%.
No, too much. Come down.
No,
He's
It's not that
guessing.
common.
Five-
It's not
five-
that common. Yeah,
5%.
less than
I'm
5, I
guessing.
would say 2
Yes.
to 3% max. Yeah. So yeah, most
Yes.
most common is the parascrotal.
Yes, these are the
Yes.
locations of undescended testes, and these are the locations of ectopic testes. So these are the other conditions which were highlighting regarding the micropenis. Very important finding that should be seen along with the undescended testes, because that gives you a clue to evaluate this further beyond this isolated case of undescended testes also. So we move to the second part now, evaluation and the management. Dr. Anupam, are you there? So
Yes, sir. Good evening, sir.
Yes, we have
Thank
finished
you,
the
sir.
second one. Yes. So you have heard the history and the story so far.
Yes, sir.
So what specific steps do you order for this case? The
So
left hemistotum, left testis is undescended.
Yes, sir. So if the on examination also, if the testis is not palpable, so the next best step is examination under anesthesia, sir. So
Best test will be okay.
yes, sir. As the
So let me
different
see.
guidelines,
Just
yes, sir.
yes. Next best test is the examination of anesthesia. You are not interested to order any test in terms of ultrasonography or MRI. Is that?
So multiple, yes, sir. Multiple studies in the literature has shown that any imaging modality cannot reliably tell that testis is present or not in case of a non-palpable testis. So
But most of the patients' parents are coming with ultrasonography in their hand and it's shown in the picture.
yes, sir, yes, sir. But it is not recommended, sir. Yes, sir. According to the guideline, it is not recommended. But yes, sir. Most of the patients come with the ultrasound report, sir. Yes, sir.
Okay.
Because the sensitivity of ultrasound is also very less, sir. 45%. The sensitivity is 45 and specificity is around 78%. So it is not recommended. But yes, in clinical practice, most of the patients get the ultrasound done, sir, before coming.
So
Yes,
what
sir.
are the current recommendations as a diagnostic algorithm for undescended testis?
So, sir, if the testis is not palpable till the 6 month of age, sir, so the child should be referred to the surgical specialist surgical specialist. And in case of unilateral undescended testis, there is no need of any hormonal evaluation. But in case of bilateral undescended testis, the hormonal evaluation should be done. But if after the examination under anesthesia also the testis is not palpable, then we should proceed for the laparoscopy, sir, diagnostic laparoscopy.
So you
So
are telling
imaging,
that if it is an isolated case of undescended testis and there are no other associated features like a small phallus or
yes, sir.
hypospadias or pointers toward DSD,
Yes, sir.
then you will not recommend any radiological test. You will also not recommend any endocrinological test also.
Yes, sir.
Is
In
that?
case of yes, sir. In case of unilateral non-palpable testis, it is not recommended, sir. In bilateral, endocrine assessment is recommended, sir, by all the guidelines. Yes.
So these are the recommendations from AUA, British associations, Canadian, and the European guidelines. So Dr. Pankaj, do you deviate from this or you follow the same?
I follow the same. Yeah.
Same.
As you said, most patients come with ultrasound.
Yes.
I think that is because of the pediatricians who get ultrasound as soon as they don't feel a testicle.
Absolutely. Yeah. So this is the test for the
Yeah.
pediatricians. Yes.
Same here. Yeah.
But Dr. Takmani is there?
Yeah.
Yes, sir. Now we are coming to your area
Right.
of interest.
So my
yeah.
question to our experts and our presenter is that, as you say, sometime you get bilateral non-palpable testis, and you rightly said that the next thing is the palpating under the anesthesia, and then go ahead if you with the procedure. Means once you do a laparoscopy, you are going to go ahead with the these things, or otherwise you have to go for endocrinal and chromosomal studies in case.
Yes.
Now, why in these circumstances, why not sonography? What is so against the sonography? Because sonography with the 7.5 megahertz probe, or even higher than that, can pick up in significant number these testes. And in that case, we can avoid the at least endocrine and chromosomal studies, which is been recommended for the bilateral and undescended testes.
So I can take Anupam to the next question to answer this. Yes, you want, what is the rationale of radiological test, if at all?
Sir, radiological tests are ultrasound and MRI. Basically, there are only few indications. In case of if the bilateral undescended testis is there, to identify the Mullerian structure, the ultrasound or MRI can be done. Means in the suspicion of the DST. And the only one in the present era, only one indication of the MRI in the undescended testis is if on laparoscopy also we could not find the testis. So to look for any topic location, we should do the MRI. This is the only one indication of MRI at present. But yes, sir.
Anupam, I have a question. What is the best investigations for the volume?
Yes.
Of the
volume, sir, ultrasound. Ultrasound is the best.
For the volume is ultrasound.
Yes,
how
sir.
You will be able to see the volume if you don't pick up the testis in the sonography?
So the Dr. Takmani's argument, Anupam, is that what is wrong if you are going with
the exact question is what is wrong in doing the sonography in
which is not very costly
cases
in India, which is not very costly in India, and going for an ultrasonography showing unilateral testes or bilateral testes in the inguinal canal, deep ring, superficial ring, or in the canal or scrotal neck, then it will stop the clinician to prescribe further testing like this endocrine or other tests also, which may be needed in subsequent cases.
If I may say something there, with your permission.
Yeah, please.
So I sometimes go backwards. Again, examination under anesthesia. Dr. Singh asked a question in obese patients.
Yes.
I think for my to minimize the stress for me during surgery to do laparoscopy, I may consider ultrasound if I want to avoid going through with a laparoscopy. Many of these kids who are obese, where there's too much of fat, it's difficult to feel a testicle. And they are many of times they're not pure undescended testes. They're high retractile testicles. Those can be easily tackled by single incision, and they're typically not with hernia hydrocele. The second question, in a bilateral non-palpable testis, the history, if it is a full-term normal baby, normal appearing phallus, and a good scrotum telling me that there are genitals there. In those cases, I would do is examination under anesthesia. If I don't feel anything, I would put a camera. If I see the testes, if I don't see Mullerian structures, I get my answer. If I do the diagnostic laparoscopy and there is something which is concerning, one, I looked at it, I know what investigations to order. It is minimal risk. And as Dr. Takwania was talking about, is yes, especially in India where limitations are there, you can avoid those extra additional tests where families are somewhat a little more shy about getting a blood drawn for a child when they think the condition is surgical. It is difficult to explain the families if they're not, they don't understand why the test has been offered. And that approach many times gives us an answer one way or the other. It doesn't hurt. And majority of times, you will end up doing either a inguinal orchiopexy or you will do a stage laparoscopy.
Correct. Because none of the guidelines, basically, they recommend ultrasonography. But Dr. Takwanis and Dr. Pankaj both have a point. And this because
Dr. Ansari,
yes, sir.
may I
Yes,
add? Yes, let me tell you, usually there is a contradiction in the literature itself. One way you say that the size is best evaluated with the ultrasonography, and the ultrasonography is not a choice of investigation for. Now, all these literature which has been created long past, that is the experience of 15-20 years back. Now the things have changed in the sense that we have a specialized pediatric ultrasonologist, and they get this. And many of the pediatric urologists themselves, they do the good sonography, ultrasonography, and they do themselves. So the ultrasonography has an important role in UDT even today. That's my submission, maybe.
But there is a
many times I would do an ultrasound because our anesthesiologists have ultrasound, which is either a 5 or a 7, and I will just grab that and put it on the patient. And sometimes once they put the patient under anesthesia and put a muscle relaxation, things change. A testis which is intra-abdominal or a peeping testicle will just pop out, and you get the answer. There is no need to go with laparoscopy. You just make an inguinal incision and you bring the testicle down.
I think we all agree that, you know, we keep doing more and more ultrasound for certain things. Because, you know, it's at the end of the day, if it's not palpable testis, it's kind of a useful tools, especially if you have like skilled radiologists who are specialized in children, ultrasound in children. So they do have, they give a little bit more information rather than just go straight for an anesthesia and the laparoscopy when you might actually know the location of the testicle beforehand.
Yeah, the problem comes is when it is not done by a specialized radiologist, as someone who doesn't do this every day.
Yes,
that's the problem.
Important.
And it is hard to convince parents that we need another ultrasound because it costs them money.
Yes.
Dr. Ansari, can I come for 2-3 points quickly? So
please.
In my experience of almost 24 years in a peripheral practice, which is a district place, over a time, our sonologist got excellent training because we are feeding them these patients as well as the machines improved. And with that, our pickup rates are absolutely fantastic. Only problem which I have seen against the sonography in my practice is the false positive. Sometimes patient is shown the relative shown the testis in the sonography, and during the exploration, if you don't find it out, then that's a problem. That's the only problem in my practice against the sonography. Otherwise, I don't find anything against the sonography, which is easily available, costing almost 700 rupees and gives excellent informations in nowadays with the excellent.
Dr. Anil, maybe you want to talk to the sonologists that they are not labeling the sites wrong. We have had 3 or 4 patients in Indiana where we have been sent patients where both testicles have been shown in the groin. We explored and we did not find anything. And the parents felt that we did something wrong.
Yeah. So that's a point only against the sonography in my practice. Because so for
I think the problem is the
reason, I always tell my parents that I'm sending the child for the sonography. It will just give me a hint what exactly I'm going to face. But otherwise, more than that, I'm not going to give this importance. But it is very important for me. But for the relatives, we have to inform them that this is just a primary guide for me, not for you. You may be happy seeing these testes in the sonography, but I will be only happy once I see during the surgery.
Yeah. So just to conclude, because this is one of the gray area where one need to deviate from the international guidelines, because this is a very common question asked by the examiners to the
And
PGs.
sir, we are talking too much about the relying on volume on sonography. One side we are talking too much about the volume. So the volume is only possible if you pick up, right?
Yes, sir. So our primary objective is not to find the volume only, because it is whether this test is seen or not seen, because that may help us to chart out our next plan as well as the counseling from the parents. But the PGs, they have to know both the aspect, because as such the guidelines say that these are not contributory, and the reason is that the specificity and the sensitivity in the various literature are very low. They should know this. But since the ultrasonography is available almost in every village and every corner of the cities in India, and this is becoming more like just a part of clinical examination. So ultrasonography is not a part of investigation now. I feel it is a part of this clinical examination now. So if you get it, there's no harm.
I think also Dr. Pankaj is right in saying that these data are biased by the fact that not all ultrasonographists or radiologists who do that are skilled in doing
Yes,
what
absolutely.
they're doing.
Absolutely. Because these are not the old guidelines. Still, it is written that we do not need any radiological test. Maybe that with the time the guidelines will change. But so far, the examinees, they have to remember this both aspect. Yes.
One last thing for trainees, your examination, spend more time in that. It's going to give you 90 to 95% of the times an answer of what you want to do the next. Yes. Don't rush into the exam. Take your own time, comfort the child, make sure he's relaxed to get the best exam. That will give you an answer to what you want to do the next.
Right. So if you find testis on clinical examination, so how do you measure the size of the testis? What are the different ways?
Yes, sir. There are different ways of to measure the size of the testis, like orchidometers available, and by using ultrasound also. So there are Seeger's two orchidometer, like Seeger's and Prader's orchidometer, in which the Seeger's orchidometer is better than the Prader's orchidometer. It is because the different studies in the literature, they have compared the finding of ultrasound and the Seeger's orchidometer, and they found that the finding of Seeger's orchidometer is best correlate with the ultrasound. So if the ultrasound is available, obviously gold standard is ultrasound only. And if it is not available, then Seeger's orchidometer can be used to assess the size of the testis.
So these are the different ways: Sagar orchidometer, Prader orchidometer, and ultrasonography. And the commonest, I think, which has been used over this decades is the Prader orchidometer. But it is said that the best ways to measure is the ultrasonography to know the volume. And closer to this ultrasonography is the Sagar orchidometer. And the Prader had, although it is easily available in most of the outpatients, because this is just a readily available tool to just to overlap these beads over the testis, but it most of the time overestimates the size of the testis. So these are some of the comparison of various types of the orchidometer, Prader, this Tekihara punch ring, and the Sagar. And the Sagar, which is I think this is the caliper measurement of the testicular size, is almost the most close to the ultrasonographic parameters. And thus there are some other studies where the testicular volumes have been studied in relation to isolated undescended testes or monitoring the testicular sizes in varicocele children. So ultrasonography is so far the gold standard, and the closer to that is the Sagar or orchidometer. So anything Dr. Shiro, Dr. Pankaj, or other expert want to add to this?
I want to ask a question to the faculty.
Anupam.
How many in clinical practice use orchidometer for measuring the volume? I don't. I'll be honest. I don't.
But
I agree with Dr. Pankaj.
Because I think we all kind of learned over time is by examining the testicle, it gives us a rough estimate if it is a normal or a hypoplastic testicle. If there is a compensatory hypertrophy, you get your answer. If it is not a compensatory hypertrophy, most of the time the other side testicle is normal.
Right.
Now it
Absolutely.
may change when they become post-pubertal or pubertal. Those are the testicle are destined, and they're going to be small no matter what. Both by size and functionally, they are pretty much hypofunctional. I pretty much say these testes may contribute 40-50% to either the testosterone, and the quality of sperms may not be normal. That's what most of the time I tell the parents.
I agree. We never use
Yes.
the orchidometer for
But for
prepubertal.
trainees, I think this is a good practice in training to use it, so know exactly what the size of the testicle should be for a particular age, so that when you go in practice, you have a rough estimate and an idea of what you should expect.
Yes, this is a very important comment, because if you are having a predator, so you should at least in the back of mind will be having some nomogram of that region in the country. And we also had one nomogram for the testicular sizes from Dr. Chandra's side, from CMC Vellore. Dr. Chandra?
Yeah, actually, we have not made a nomogram. We looked at, I mentioned about the uroflowmetry nomogram that I have sent, but ultrasound, we will do one.
Yes. But there's a volumetric has from the Department of Pediatric Surgery from the CMC.
That's correct.
Itself.
Yes. Yeah. They had sent that.
So is there a role of endocrine workup in this case?
Sir, yes, sir. As discussed in the previous slide, sir, all guidelines says that endocrine workup should be done in case of bilateral undescended testis in suspicion of the DST, sir. Because these patients, most common clinical condition associated in these patients is congenital adrenal hyperplasia, sir. So, yes, sir.
When do you suspect DSD in cases of bilateral undescended testis?
Sir, if there is a associated genital abnormalities like hypospadias or micropenis or the bifid scrotum, and there are few other signs also like a dimple in the perineum, sir, or long anoscrotal distance. These are few signs which means raise the suspicion of the DST, sir. So
exactly.
First we have to rule out the congenital adrenal hyperplasia, sir.
Okay. So obviously, if you are having a bilateral undescended testis, the recommendation is that at least the commonest anomaly of DSD should be ruled out. That is 17-hydroxyprogesterone level and two more hormones. That is this gonadotropins, luteinizing hormone, and follicle stimulating hormone along with testosterone should be done. So that gives a basic idea whether there is an occurrence of this DSD or not. Then in the clinical examination also, you have to be little careful while examining. And Dr. Bhatt is kind enough to provide from his book. These are some of the features which may suggest the occurrence of the DSTs with this undescended testis. But remember, undescended testis alone on one side, it can also be associated with DSDs also. We should not be under this impression that only the bilateral undescended testes are associated with DSTs. But there may be some cases very little undescended testes. Maybe that we have this slide in subsequently, which we'll discuss this aspect also. So these are the dimple in the perineum, dimple and discoloration in the perineum, bifurcation of the median raphe, and Dr. Pankaj and Dr. Bhatt both were highlighting, and long anal scrotal distance, and this has been seen the influence of this androgen, and this short distance and long distance both have their connotation in terms of occurrence of the undescended testis. And obviously, microphallus quickly gives a clue about this association of DSDs also. Hypospadias with patulous urethral opening also gives an clue to the occurrence of the DSD in these cases. Very wide opening of the external urinary meters like penoscrotal or perineal. These are all cases of possible DSDs. Then this is another picture which is provided by Dr. Bhatt also, and this is the anogenital distance with the scrotoperineal this raphe, and from the midpoint of the anal which has been seen. And all these aspects, these have the occurrence of this undescended testis also. Then various anomalies in the median raphe of the scrotum also, or they may be simple perineal sinus also that may also be suggestive of DSTs. So any other point, Dr. Bhatt, Dr. Pankaj, Dr. Siro or Chandra?
Can we go back to the previous slide, Dr. Ansari, please?
Yes, please.
So it's very interesting that Dr. Bhatt has shared his slides for the trainees. I'll be honest, we in the Caucasian population, we don't see the dimples or the discoloration of the perineum like you have illustrated in figure A, the figure B, and how the D looks like that median raphe is so prominent. Maybe because our patients are more Caucasian white skin, and I may have to start looking that at carefully. The many we have seen and done, they typically have a normal anorectal distance. I wonder whether this is specific to our Indian subcontinent.
May I speak something?
Yes, please, sir.
It's this science, it's not necessary that normal may not have. But if you find any of these signs are indicative of the Mullerian duct remnants inside.
Right.
Okay.
So Mullerian duct remnant may be without these signs also, but with these signs, they have to be evaluated, and you will find the Mullerian duct remnants in these patients.
Okay. It's not specific for undescended testes, is what you're saying.
Yeah, undescended testes with all these. Undescended testes, hyperpedias with undescended testes, even unilateral undescended testes with any of these signs. Then you should evaluate for, you see, bilateral, usually we go for one. But even in a one-sided undescended testis or any of these signs, then these patients should be evaluated.
Okay.
Okay, that's helpful to know. Thank you.
Yes. So these are all theoretical aspects which has been discussed so far. So since we were talking about the bilateral undescended testis, when would you suspect anorchia?
So basically, sir, in case of if the on evaluation the CAH is ruled out, sir, congenital adrenal hyperplasia, then we have to do some additional hormonal testing, sir, to find out is there anorchia or not. So the most sensitive hormone is the Mullerian inhibiting substance, sir. It has a sensitivity of around 90 to 95% and specificity of 98%, sir, to means for anorchia. So we have to, and we should also do the additional like FSH and LH level also. So in any case of bilateral undescended testis, if the MIS or inhibin B are non-detectable and serum FSH and LH are high, then it gives the means it 100% means says that it is an anorchia. Then further any evaluation is not even neither laparoscopy nor any imaging is required to document the anorchia. According to the current guideline, yes, sir.
But undescended testis with hypogonadism will also result into high level of LH and FSH. How do you?
Yes, sir. That is why MIS is means we have to do all the testing like serum FSH, LH with along with the MIS and inhibin. Yes, sir.
So
because yes, sir.
go.
Previously the SCG stimulation test was done, sir, but in case of testicular dysgenesis, the serum testosterone may fail to increase after the SCG stimulation. So it is a non-diagnostic of anorchia nowadays. Most sensitive is MIS level, sir, nowadays, yes, sir.
Okay. So just raised this gonadotropins may not point out towards the anorchia, but you have to prove it by either going for this MIS or anti-Mullerian hormone, both are the same, as well as the inhibin. So are you aware, Anupam, from where they come? This anti-Mullerian hormone and inhibin?
Yes, sir. It comes from the this one, sir. Sertoli cell, sir. Sertoli cell by stimulation, endogenous FSH stimulate the Sertoli cell, and that produces the MIS and inhibin B, sir.
Okay, so both are the source from both are
Sertoli cells.
Sertoli cells.
Yes, sir.
Okay. Okay, so we move quickly to the next question. Do we need any karyotyping in this case?
Yes, in this case, obviously not, sir. In case of unilateral undescended testis, the karyotyping is not required, sir. But only it is recommended in case of bilateral non-palpable undescended testis. And again, to rule out the DSD.
You have to revise your statement in isolated non-syndromic.
Yes, sir.
Undescended
Undescended
testis.
testis.
We
Yes,
do
sir,
not
yes, sir.
need. We do
Yes,
not
sir.
need. Yes,
Yes,
if
sir.
undescended testis associated with other stigmas, yes, then it might need.
Yes, sir.
Is
Definitely,
that
sir.
correct?
Yes, sir. Yes, sir. Yes, sir.
So these are the karyotypic to confirm exclude the dysgenetic primary hypogonadism, and specifically it is indicated in all these cases what we have done in what case scenarios you will advise endocrine workup. So same will be applicable here also.
Yes, sir.
Yes, Dr. Pankaj. Dr. Bhatt, Dr. Siro.
I think the part is covered along with this, sometimes
Yes.
with other associated anomalies.
Yes.
Like this, many patients with the cardiac problems, they have with the syndromes or this one, and bilateral undescended testis with any of these, or many a time with the duplication of the urethra.
Okay.
One of the, so they also needs this type of evaluation. And penis size, usually you see, though we mention frequently micropenis is rarely diagnosed, but the size of the penis as per age, the nomograms I have given, that is in my book also, and in Indian Journal of Urology for Indian people, I have given nomogram. Go with that nomogram, and if the penile length is less than 1 centimeter of that age group, then you should go for these evaluations.
Okay.
I agree. As Dr. Bhatt and Dr. Ansari said, any patient who is syndromic and has findings which are out of ordinary and don't look normal, like a flat scrotum or a sign suggestive of CAH, or a wide perineum where it feels like it's more like a female pelvis or a perineum. You expect some Mullerian structures in those cases, and those are the ones I would get a karyotype and a genetic testing.
Right.
In a normal male with the undescended testes, with a normal phallic appearance, normal rugated scrotum, I wouldn't do it.
Right. So moving to the next question. Suppose the baby had come to you at first week after birth. What could you advise the parents?
Sir, first I will ask, means I will take some history, is there any visible or palpable swelling they have noticed in the inguinal canal or scrotum? Means to just to rule out the retractile testis. If not so, we will assure the patient parents that at around up to around 6 months, most of the undescended testis spontaneously descend. And if it spontaneously descent is not done by the 6 months, then we have to means move further for the evaluation and management of that. So if the child present at the first week of birth, then we will reassure the parents, sir, that we have to wait for the 6 months. Yes, sir.
Anupam, let me just ask, can you quickly describe what you see in that picture? You mentioned everything is correct. Just describe that picture because you saw that.
So Dr. Priyank, quote you, Anupam.
Yes, sir. Sir, in this, sir, left hemiscrotum is empty. Okay. Yes, sir.
So this is a very old picture. Not
Yes,
a very
sir,
good resolution also, but somehow because the camera phones were not that.
Yes, sir. Because sir, it looks like retractile testis, sir. Because the scrotum is means left hemiscrotum is also well developed, sir.
It is well developed. It is pulled up.
Yes, sir. Yes, sir. It is well developed scrotum and testis is pulled up, sir. Like retractile testis, sir. Yes, sir.
Yes. So obviously, you have to ask all this. Look for the retractile testis, and whatever may be the conditions. If the retractile testis is there, then there is no problem. But even if there is no tissue palpable in the scrotum or in the inguinal canal after careful repeated examination, then obviously you have to observe this case for 6 months.
6 months at least.
Yes. So, Dr. Bhatt, we move to the next question. What is the timing for elective surgery? Yes. And what are the goal of treatment?
So the time is for timing of elective surgery. The orchidopexy should be done between the 6 and 12 months of age and latest by 18 months of age. Because multiple studies in the literature say that there is a progressive loss of germ cell in these testes beyond the 6 months of age, and if the orchidopexy is done before 1 year also, then also around means the risk of fertility in these children is about 25%, sir. So we should should not wait more than 1 year or latest by 18 months for the orchidopexy.
Okay. So yes, as you rightly said that this has to be fixed between 6 and 12 months and not later than 18 months. And because there is a rationale for this, there are the various grades of recommendations and level of evidences also, and all available on the literature. And the rationale.
Yes, sir. Yes. Goal of the treatment is to improve the fertility and to decrease the risk of malignancy, sir. Because the main concern is in these children is fertility and the increased risk of malignancy.
Okay.
Yes, sir.
Sorry. Yes. Go ahead. Can I?
Please.
Yeah, there is actually a recent meta-analysis that shows that there is a lower risk of morphological changes in the testicle if it's the orchidopexy is done between 6 and 12 months. So it's even better if below it's even better not to wait even after a year. It should be operated between 6 and 12 months.
Means before 6 months, sir?
No, before 12.
Before 12, okay, sir. Okay,
so not even wait 18 months. It's better. Yes. It's in between 6 and 12 because there are way less morphological changes and the growth of the testicle is it's improved at the puberty.
Right, I fully agree.
Dr. Ansari.
Yes, sir.
May I speak something?
Please.
Yes, the thing, you see, I think we should take up this matter and especially to our pediatrician colleagues, and we should give a lectures in their department, because most of the time you will say they still in my practice, what I get from the patients, what they tell is that you wait for 5 years. This is the message which is given by because first time the child is being seen by the pediatrician. So this message has to be passed strongly to all our pediatric medicine people. That's all. Thank you.
Sir, I had a pediatrician admitted under us and the wife was gynecologist. He was admitted under us for infertility. Okay. On examination, the pediatrician was found to have bilateral undescended testis.
That's why I'm telling. That's why I'm telling. So this message has to be passed because ultimately the patient is at risk.
Yes, absolutely. So the
risk, we have to take care of the patient.
Yes, what Dr. Bhatt is highlighting, what are the risks or complications if we do not treat this? If we take the philosophy of 5 years.
So, sir, the risk of infertility in the unilateral crypt orchid testis is around 10 to 30%, sir, and the prevalence of azoospermia in these patients is about the 13%, sir. However, in case of untreated bilateral undescended testis, the prevalence of azoospermia increase up to the 90%, sir. So earlier the treatment, the better the fertility. So the first one is the fertility, and second one is the malignancy, as per part says, sir. So overall, the risk of testicular malignancy in undescended testis, if the orchidopexy is done after the puberty, is 5 to 6 times than the general population. And if the orchidopexy is done before puberty, it is the risk reduced around to the half, that is 2 to 3 times that of the general population.
Okay.
So yes, sir.
Dr. Ansari.
Yes, sir.
Now, regarding this, the pediatricians' participation in recently concluded Lisbon conference, there was a presentation based on this, the effect of the combined flipped classroom and simulation-based education on pediatricians' physical exam and management of undescended testicles. And they said that prior to this program, entering into the program in the simulation, their skill of picking up these conditions and managing in a right way was around 27%, which can improve to 93% after this flipped classroom and the simulation.
Right. So just to repeat what has been discussed, in cases of unilateral, the infertility can result in 10 to 30%. In cases of bilateral, if left untreated, it is almost 90%. In the malignancy also, it has been studied that overall risk of testicular cancer, if orchopexy has been done before puberty, it is 3 times. If the orchopexy has been done after this puberty, the risk almost doubles, that is almost 6 times. Maybe that we will be discussing this study in subsequent slides also. Yes. So Anupam, the next test, yes, we welcome Professor Anish Srivastava also, sir, because this is only one-sided way, and so I do not know whether you can be unmuted or not.
No.
Okay, sir. Thank you very much. Thank you, sir. Thank you. So Anupam, what is the determining test or feature suggestive to decide on open or laparoscopic intervention in child with UDT? In the meantime, Dr. Pankaj Dangle has gone to meet one of his friends. He will be back in few minutes. Yes.
So every time, sir, if we are subjecting a child for examination under anesthesia, so we have to take the consent for the laparoscopy in the same setting if the testis is not palpable on examination under anesthesia also. So all the cases of this means undescended testis which are not palpable under anesthesia, they can be managed by laparoscopic intervention. There is no need of open intervention until it is a inguinal orchidopexy. So this is the way to decide open or laparoscopic. So basically all cases are managed with the laparoscopic intervention only until it is a inguinal orchidopexy.
Yes. So this is the standard algorithm which is usually available in most of the guidelines and the textbooks also. If the testis is palpable, the story always starts after examination and anesthesia. Whether ultrasonography is showing or not, clinical examination is showing or not, you have to reconfirm it. If the testis is palpable, standard inguinal orchopexy has to be done. Not palpable, then you have to proceed with a diagnostic laparoscopy, or when the facility is not available, one may go for the inguinal exploration also, and then proceed superiorly. And another question which may be asked about this, what are describe the relevant steps of orchopexy, and so, commonly asked in exams also.
Yes, sir. Yes, sir. So patient in the general anesthesia in supine position, sir, basically first examination under anesthesia and done, and we have to identify the lowest testicular position, sir. So if it is a means on the basis of that only we have to go for either laparoscopy or inguinal orchidopexy. So if it is in the palpable in the inguinal region, sir, so we proceed with the low transverse Langer's line incision, sir. Means superior lateral to the pubic tubercle. It means at or below the inguinal.
Where will you give the incision?
At the deep ring, sir. Means at or below the deep ring, sir. At or below the deep ring, sir.
So where do you find the deep ring?
Sir, midway between the anterior superior iliac spine and pubic tubercle, sir.
Pubic tubercle, correct.
Yes, sir. So then we'll dissect the subcutaneous tissue, and we have to look within the superficial inguinal pouch, sir, for the possibility of the ectopic testis, sir. And if it is not so, so we will proceed further to incise the external oblique fascia to expose the inguinal canal. After that, we will spermatid cord is isolated, and testis is dissected distally to attachment to its gubernaculum, and gubernaculum is transected distal to the sac. So in about 90% of cases, a hernial sac is found. So if that's so longitudinal incision of internal spermatid fascia is done to isolate the sac, and dissection is done up to the deep ring, which is then suture ligated. So after that, means if required, the additional mobilization can.
Stop, Anupam. If
Yes,
hernial sac is present, I
Yes,
will
sir.
ask the Dr. Takwani's question. What is the relation of hernial sac to the cord? Where will you find it?
Yeah, so
So-
you have to open the hernial sac to get the
And where will
testis.
you find it? What is the
Right,
correlation of cord to the hernial sac?
Yeah. So see, I sent the picture, but I was late. It is with the Priyank. And if you want me, I can share little bit of screen if you allow me.
Oh,
You
yes,
allow me?
yes, because
I think it is posterior medially,
oh,
sir.
you can come, you can come.
So this is the only picture actually I wanted to show. Can you see this picture?
Yes,
So
sir.
make it, sir, bigger, make it bigger.
Yeah. So this is how, this is the gubernaculum. This is the patent processes vaginal, this processes, and there you can open it up and you can see the testis. What we are seeing is the visceral layer of the patent
Peritoneum.
processes vaginalis.
Yes, sir. Yes, sir.
So it appears like a peritoneal content, but it is not truly a peritoneal content because there is a visceral layer. Now, if this is blocked here and it is truly a descended testis, then this would have become tunica vaginalis, which is having a parietal layer, and this is a visceral layer, right? So here also this is a parietal layer and this is a visceral layer, but you can reach up to the testis only after opening this. Now, in a easily mobilized testis, which is the most of the time case, it is better not to deskeletonize all these things. Let this peritoneum remain there, right? And just mobilize at the deep inguinal ring for the high ligation purpose or closing this hernial sac. And then you can make a subdartos pouch and put it into there without any tension. You make sure that there is no tension and then suture this subdartos pouch. This is the relation. This is what it is. It is the visceral layer of the peritoneum or patent processus vaginalis, right? And this is what is the, we can say that.
So Anupam, now the picture is in front of you. Can you describe the relationship of this tunica, this processus vaginalis to the cord? Now the picture is in front of you.
So cord, yes, sir. Cord is posterior medial to the sac, sir. Posterior medial, sir.
Say no. This is absolutely. See here. Can you see my arrow? No.
No,
you
sir.
cannot see because this is the Dr. Takwani. The sac is superior medial and the cord is posterior lateral. See?
Posterior lateral.
Superior medial towards the penis is this.
Yes, sir. Yes, sir. Okay, sir.
Superior medial. This is the relationship. So
Yes, sir.
So will you permit Anil sir to share my slide again?
Yeah, I'm stopping this
Yes.
sharing. Just give me a minute. Thank you, sir.
Okay. So going to the next slide. This has been done, the steps of the orthopexy. Yes, what is Bianchi's orthopexy and which cases are best suited for it?
Bianchi orchidopexy is basically for low palpable undescended testis, sir. That is all the inguinal testis or high scrotal testis in which the single incision orchidopexy is done. If in case of unilateral cases, high transverse scrotal incision is given, and in case of bilateral low palpable undescended testis, a single midline raphe incision can be given. So it is a single incision orchidopexy for low palpable undescended testis, sir.
Okay.
Yes, sir.
So let me see, do we have
I have
something
a question
this?
for you,
Yes,
if I can.
yes, please, Dr.
So
Shiro.
what's the first thing you want to do when the patient is asleep before starting the operation?
Sir, I didn't get, sir. Sorry, sir.
What's the first thing once the patient is asleep before starting the operation? What do you want to do? You might want to re-examine the patient in case you want to change the approach, because sometimes you have, like, when you examine the patient in clinics, you might have a different idea what's the location of the testicle. But once the patient is asleep, you may actually want to change your approach and do a Bianchi rather than just an inguinal approach.
Yes, sir. Sir, we have
Always examine your patient once he's asleep before you start the operation.
means that we have to examine under anesthesia to look for the lowest possible location of the testis, sir. On the basis of that only we can proceed with surgery to be. Yes, sir.
Anupam, you say, I will reconfirm my findings, what has been
Okay,
done
okay.
previously. Yes, you
Yes,
reconfirm.
yes.
This is very important, because if you are pre-programmed that I will do Bianchi, the location may change in anesthesia,
Yes, sir.
may
Yes, sir.
not be
Yes, sir.
suitable.
Yes, sir.
Okay, this
Yes,
is
sir.
what
Yes, sir.
Dr. Chiro is saying. Always
Yes.
re-examine. Yes.
Yes, sir.
So this is basically modified scrotal. This can be done by single lateral incision, or this can be done by midline incision also. And this is all when it is suitable for both. This is for inguinal or the canalicular, as well as the testis of the scrotal neck. Because both the you need not to open the inguinal canal here from lateral pre-incision. You do the inguinal part also, and you create the subdartus pulse also.
Yes.
While in cases of bilateral, you can get away with midline also. The steps are the same. So we're moving to the next question. Is there a role of biopsy at the time of orchopexy?
Sir, there are only few indication of biopsy at the time of orchidopexy. First one is in case of bilateral crypt orchidism for diagnosis of DSD, sir. And second one is as the incidence of CIS is more in the patients older than 13 years of age. So to identify these finding in if we are doing orchidopexy in means male older than the 13 years of age. And there a few literature also says that we have means to improve the fertility, we may take the biopsy to know the potential candidate for gonadotropin therapy. So these are the few indication of biopsy. Otherwise, in case of unilateral cryptorchidism, there is no role of biopsy, sir. If the opposite testis is normal, yes, sir.
So routinely, it is not recommended.
Yes, sir.
As a protocol, but in cases when you are having suspicion of DSD, then obviously to determine the genetic sex, you have to biopsy the this gonad.
Yes,
and to identify the potential candidate for gonadotropin therapy. And this one highlight from the literature that gonadotropins in undescended testes, because of the previous germ cell injury, may get improved if these kids are treated with gonadotropin therapy during their childhood or adolescence. And it has been shown certain results, certain studies that spermatogenesis has improved with intervention with gonadotropin also. And in another scenario where the biopsy may be indicated if it is a post-pubertal case of undescended testis. And we have this study, I think this will be coming in New England Journal, okay, why it is relevant to do biopsy in post-pubertal kids.
Yes, sir.
So that we will be discussing subsequently. So coming to the next, yes. What is the role of laparoscopy and its accuracy in detecting undescended testes?
So, sir, we have already discussed this, sir. Means in case if after examination under anesthesia also, if testis is not palpable, then we have to do the laparoscopy, sir. And we have to look for the findings, yes, sir. Certain finding which can which can guide us what to proceed further, sir. So various studies are there. Means laparoscopy is highly accurate, sir, to diagnose the anarchy or location of the testis. Yes, sir.
After this examination anesthesia, that will guide you to plan whether you want to go for the inguinal exploration or you want to go for the diagnostic laparoscopy and subsequent laparoscopic intervention.
Yes,
so
sir.
how to decide single stage or staged orthopexy?
So if the sir on laparoscopy, if the testis is near the deep ring, sir, so the single stage orthopexy can be done. That is defined as within 2 centimeter of the deep ring. And if the testis is too high, that is 2 to 4 centimeter away from the deep ring, then stage repair should be done. It has given that stage follower stiffer has a better result than a single stage repair, sir.
So if it is a palpable testis, low or high inguinal, that most of the time can be done with straight away inguinal exploration. The only question comes when it is a non-palpable testis under anesthesia. Then laparoscopy is obviously the treatment of choice, and that you have to decide whether you want to go for single or two-stage procedure, and based on certain findings. And this is what the testis near the deep ring, within 2 centimeters for the deep ring, can be taken away with a single stage, while the testes which are located high or 2 to 4 centimeters away from the deep ring, then it has to go ideally with stage follower stiffness orthopexy. So coming to the next, so these are the steps.
There is someone asking, how do you use, what do you use to measure the distance in doing laparoscopy? I would use the tip of the instruments. You know what's the length of the tip of the instruments when you do laparoscopy.
Oh, yes.
So it's a kind of an approximation. But you know, for instance, whenever there is a pencil is about 1.5 centimeters or 2 centimeters that opens up, you know the distance, and you can use that to measure the distance between the testicle and the internal ring. So I saw that someone else just asked a question. That's why I was.
Yes, absolutely, absolutely. Because yes, what Dr. Chiru is telling, the tip of the instrument, you already have measured it before going in. So that gives an idea. Usually, I think Dr. Chiru take it 1.5 centimeter, the tip?
Yes, yeah.
Oh, yes. So that gives an idea how far it is from the deep ring. So these are the steps. You make medial and the lateral peritenotomy. You do not make too much dissection around the cord. You simply dissect it and just put 2 clips, 1 to 2 centimeter apart like this.
And I like to say one more thing, sir. It is also written in the literature, sir, that if after mobilization of the testis, if that testis is can reach to the opposite deep ring, then it gives a rough idea that it can be brought down up to the scrotum for single stage orthopexy.
No, it is broad, but you have to decide sometimes before making any dissection.
Yes, sir.
You do not want to do unnecessary dissection when you know that this testis will never be able to reach to the scrotal neck. What to say about the bottom of the scrotum? So that is the basic idea behind this follower stiffness procedure.
Yes.
So what is the principle of follower stiffness orchidopexy?
Basically, sir, the main limiting factor for the mobility of the testis in case of undescended testis is the length of the testicular artery, sir. And testis is also supplied by the artery to the vas and cremasteric artery. So in the follower stiffness, what we do in the first stage, we clip the testicular artery. So the testicular artery means testis get a robust collateral from that artery to vas. So later we can do the stage repair. Yes, sir. To means and the vascular supply of the testis will also be preserved. So this is the basically the robust collateral from the artery to vas is the principle of the follower stiffened artery. Sir.
Okay, basically this have a triple blood supply.
Yes,
one is the testicular artery to vas and the cremasteric artery. So if you clip the testicular artery, then the collaterals they will develop between the artery to the vas and some fibers from the cremaster also, and that will result into the survival of the testis.
Yes.
So, and this is the picture. I think this is this. So what we create, this is, I think, is the triangle, the golden triangle between the vas and this cord.
Okay.
And when we go for this is the triangle which has to be preserved doing for fall defense procedure. So at least this triangle nearly 2 to 3 centimeter has to preserve so that this area can result into the development of the collateral. You need not to go to very close to the vas because you have to leave some area virgin
Yes, sir.
where the collaterals have to develop here. Then you can apply, you make minimum peritonitis on either side of the cord and you put 2 clips on either side and just forget. So what are the long-term results of Fowler stiffness orthopexy?
So, sir, the success rate is around in the various series. It has been given around 60 to 90%, sir. And for single stage Fowler Stephen, it is around 50 to 60%. And for staged orthopexy, the success rate improved up to the 90%, sir. So it has been means given in the EAU 2023 also based on the recent studies. Yes, sir.
Eventually, this has been a 2-stage procedure, but some authors have tried single stage, and the results they produce compromised results. And 1-stage Fowler defense has always given inferior results as compared to the 2-stage procedure.
So, Dr. Ansari, if I may ask a question.
Please.
Yeah, this is about this application of the clip. In smaller infants, you use a 3 mm ports, right? So in that case, do you use a tie or how do you do?
So in cases of if you are using 3 mm port, there are 2 options. You may use tie, or you can at least change 1 3 mm to 5 mm. Just for 5 minutes, you put the clip.
Okay, at that time of clip application. Okay, sure.
Yes.
Okay.
Okay. And even because this is just such a controlled procedure, you need not even to use 5 mm port. You use the 3 mm port, just enlarge the skin wound and put the clip applicator through that wound. Your work will be done.
Yeah. Okay. Okay.
So Anupam, this is.
Yes.
Anybody use a different
What to do when you explore the inguinal canal, but you find this?
So it could be, sir, means testicular nubbin, sir. So it depends. It is means if it is a unilateral and opposite testis is normal or hypertrophied, then means it testicular nubbin can be excised, sir. But in literature, what we have seen, sir, means multiple studies are there which have done the orchidopexy of the means excision of the nubbin, and then after that they subjected the nubbin to the histopathological examination, and they found there is a no viable tissue in the these nubbins. So basically, the issue is the malignant potential. So if the means according to these studies, the malignant potential is very low. So we can excise these nubbins, or we can preserve this also in case of bilateral. But again, in case of bilateral, first we have to do the hormonal evaluation to look for any functional tissue within the testis. So this is the
Dr. Chiru,
in case of
your
unilateral, we
thoughts
can
about,
excise, sir. Yes, sir.
Okay, Dr. Chiru, your thoughts about this atrophic testis, what has been addressed as nubbin testis? Dr. Chiru?
Sorry, was a question for me?
Yes, yes. For you, what are your practice in such cases when you find a small atrophic?
What would I do?
Yes.
Yeah, I would remove it.
You will remove it.
Yep.
So these are some of the recommendations. If it is unilateral, obviously, if opposite testis is normal, then you need not to have a second thought. You may remove it because some of the literature, very few studies have shown that there may be some living germ cells which have a potential to convert into the malignancy subsequently. But in cases of bilateral, there may be some situations where you may find bilateral atrophic testis also. But for that, you have to evaluate these further to do certain tests, hormonal evaluation, and at least to have this FSH and LH, to that will further guide you whether to preserve this tissue or not. And this is a study from Australia, which concludes that testicular nubbi do not have viable germ cells, and therefore no need to be excised on the basis of any malignant tissue. But on the contrary, there are certain other literature which shows that all the nubbin may not be non-viable. There may be few viable cells which may later on convert into malignancy. So in cases of this unilateral, you may remove it, but in cases of bilateral, you have to be little cautious and evaluate further. And these are the tests which have to be done further that will guide you whether to remove tissue on one side or both the sides. So this part 2 of this discussion is also over. And Anupam, thank you.
Yeah,
And
thank
we
you, sir.
move to the third section of this symposium, that is the general discussion and the viva. Himanshu, are you there?
Sir, good evening, sir.
Okay. So you are ready?
Yes, sir.
So the first question to you is, tell us in brief about the theories regarding descent of the testes.
So, sir, there are a lot of theories regarding testicular descent, but all the theories, most of the theories, they revolve around the gubernaculum. So, some of the theories like gravity theory is there, in which the growth of the gubernaculum pulls the testis down. There is an involution theory where there is a atrophy, degeneration, or shrinking of the gubernaculum, which makes it less bulky, and that's why the testis comes down. There are also, apart from these theories, there are certain other theories like propulsion theory, in which the increased intra-abdominal pressure leads to the expulsion of the testis down, but it has not been justified in most of the situations.
So you told these are the various theories which contribute to the descent of the testis. And so to execute these theories, what are the different factors contributing to the testicular descent?
Basically, testis descent occurs in two distinct phases. One phase is the transabdominal phase, and the other one is the inguinoscrotal phase. So the transabdominal phase is mainly regulated by the INSL3, which is secreted from the Leydig cells, and the inguinoscrotal phase is mainly regulated by the testosterone, and the INSL3 attaches to its receptors, and it increases the cyclic AMP pathway, which increases the kinases, and there are various pathways like neurogenesis pathway, WNT pathway, and the bone morphogenetic pathway, which increases the bulk of the gubernaculum. And in the transabdominal phase, the gubernaculum develops and grows. And there is in the inguinoscrotal phase, there is the involution of the gubernaculum, which finally allows the testis to grow through the inguinal canal.
Mm-hmm. So basically, the important these proteins you mentioned is the insulin-like growth factor. Yes.
Yes, sir. INS.
So that basically acts on the gubernaculum, and that makes it to grow further and help in the descent of the testes. What are the genes and the harmonic agents deciding testicular development from the primordial germ cells?
Genes can be differentiated into three types, like genes that form the sexually indifferent gonad, genes that determine the sex, and genes which drives the differentiation into male or female structures. So genes that form the sexually indifferent gonad is mainly the SF1, steroidogenic factor 1, as well as WT1 gene. The genes which determines the sex are SRY gene and SOX9 gene mainly. And the genes which drives the differentiation into male or female structure is again guided by SF1 and WT1 together with WNT4, which takes the pathway to the female side. So basically, the genital ridges initially they are formed at the 4th week. After that, the primordial germ cells they arrive at the primitive gonad, and they invade the gonadal ridge at week 6. and then the presence of the SRY gene, which influences their development into the testis.
What is the other name of this SRY gene?
Sex related. I know the
Testicular determining factor is the same.
Oh yes, sir. Yes, sir. Yes, sir. Testicular determining factor. Or
so if SRY gene is present, it is biopotential gonad,
yes,
which comes through the primordial germ cells. Then
yes. Then it comes to
yes. If SRY gene is present, then it will become.
If it is present, yeah, if it is present, that influences into the male testicular development.
If it is absent, then it will go.
It goes
into the
female pathway. Sir.
Female pathway. Okay. What is mini puberty in context to undescended testis? What is the relevance in undescended testis?
Basically, these are the mini puberty is the reactivation of the hypothalamic pituitary gonadal axis, which occurs at 1 to 3 months of age, in which the various hormones levels are increased, and which helps the neonatal gonocyte to convert into the adult dark spermatogonium. And in undescended testis, that particular step is not due to the mini puberty is not there. So that particular first step in the conversion of gonocyte to adult dark spermatogonium is hampered. So it does not proceed towards the development of adult dark spermatogonium.
So the mini puberty is a normal phenomenon in occurring infants during the phase of 1 to 3 months. The basic philosophy behind this is that the infantile germ cells, they have to convert into adult types of spermatocytes.
Yes,
and because there is a hormonal surge of SH and LH, it is also said that this may be normal physiological phenomena, but in undescended testis, this may work as a counterpoint, and this may affect the spermatogenesis on long-term basis. So this is described in context of mini puberty, the adverse effect of mini puberty in undescended testis, because these testes are already into some germ cell arrest or some ongoing injury, and this high surge of FSH and LH that further damages this growing spermatocytes. That is why it is said that the mini puberty in occurring in cases of undescended testis may have long-term adverse effect on spermatogenesis.
Yes, sir.
So coming to the next question. What is the role of gubernaculum in testicular descent? We have been listening it since beginning.
Yes, sir. Sir, as we have previously discussed also, the entire testicular descent theory, they revolves around the gubernaculum. There are 5 phases of development of the descent of the testis. Phase 1 is when the caudal mesonephros, they contact the future gubernaculum at the internal inguinal ring. Then there is a phase 2. This occurs at around 4 to 5 weeks. Then there is a phase 2 in which the genitofemoral nerve is formed, and it releases the CGRP, which helps in the formation and swelling of the gubernaculum, all the abdominal, interstitial, as well as the subcutaneous portions. And then phase 3, when it is around 10 to 12 weeks, when the growth of the testis occurs, and then the regression of the Mullerian ducts and mesonephros occurs. After that, the phase 4, which is basically the development of the gubernaculum, all the growth factors, they act to increase the size of the gubernaculum and further development of the cremaster muscle, as well as the cremaster muscle, as well as the processus vaginalis, and the widening of the internal inguinal ring. And the last phase, when there is a descent of the testis to the inguinal region. So that phase is basically when the gubernaculum is involuting.
Okay. So these are the different 5 phases which you told about the descent of the testis and the role of gubernaculum through various phases. So you also talked about this CGRP.
CGRP.
What is this? What is this? What is the role of this genitofemoral nerve or CGRP?
It is actually calcitonin gene-related peptide, and it is detectable as early as 7 weeks when the genitofemoral nerve develops, and this genitofemoral nerves stimulates the release of this calcitonin gene-related peptide, and it stimulates the development and function of the gubernaculum. Basically, it acts as a neutral to the gubernaculum's growth.
So the release of calcitonin gene-related peptides from the genitofemoral nerve, sensory nerve endings, stimulate the development and the function of the gubernaculum. And the gubernaculum basically has very important role. It also passes through the various physiological phases. Initially, this enlarges, this imbibes water, becomes bulky, and the wet mass of the gubernaculum increases under the stimulation of this CGRP, and before the complete descent of the testis occurs. And last phase of this, what we say, the involution or the contraction of the gubernaculum, which is activated during the last phase of inguinal-scrotal descent of the testis, so that the testis is placed into the bottom of the testis.
Yes.
So how do we differentiate between two clinical conditions, a retractile testis and ascending ectopic testis or acquired cryptorchidism?
Acquired cryptorchidism is undescended testis, which was already documented as having scrotal at a previous examination. While retractile testis, it can retract easily out of the scrotum, and it can be manually replaced in a stable scrotal position, at least temporarily, until there is a recurrent stimulation which leads to the retraction of the testis.
So these are some of the features between the two conditions.
The two conditions in acquired cryptorchidism, the presentation is usually like in the 8 to 10 years age group. There is a closed processus vaginalis. There is a normal epididymis, and it is a lower position distal to the inguinal canal. While the retractile testis, there is the studies shows that the testicular volume is reduced, as well as there is a higher incidence of ipsilateral patent processus vaginalis, as well as epididymis is also not normal usually in the retractile testis. These are from based on some studies.
Okay. So what is the transverse testicular ectopia? Which condition is classically seen in?
Transverse testicular ectopia is where the both the gonads they migrate towards the same hemiscrotum, and it is usually associated with it. Actually, it is 3 types. It has been described. Whether type 1 is associated with unilateral hernia, and type 2 is associated with persistent Mullerian duct syndrome. Type 3 is associated with other anomalies, which are like anomalies of the vas deferens. There is a seminal vesicle cyst, or there may be testicular microlithiasis, means other than that persistent Mullerian duct syndrome.
So these are the 3 types of this transverse testicular ectopia, and in the type 1 only hernia is there. Second, it is associated with persistent Mullerian duct syndrome, and the type 3 is which may be associated with other hypospadias, scrotal anomalies, along with this persistent Mullerian duct syndrome. And these are some of the pictures of this transverse ectopia, which is showing the testes, because basically in transverse ectopia, both the testes, they come through the same inguinal canal to lie in the same scrotal sac. It may be located in the scrotum properly, or it may be just in the scrotal neck also. As you can see, both the testes coming through the same inguinal canal. Here on the exploration, you find same testes. So both the testes, they're coming to the same inguinal canal. So, and the next question is, this is another picture showing this. How do we bring down these testes in such cases?
Whenever we have a clinical suspicion, we confirm our diagnosis with laparoscopy, and the main thing is to assess the testis, the vas deferens, and the vessels. And if there is the adequate length, we'll do transseptal orchidopexy. If it is severely inadequate, we'll fix the both in same scrotum. Like this is the algorithm which we bring down the testis.
So this is the simple sketch which is showing both the testes which are lying on the same, and yes, if they are lying on the same scrotal sac, then you may do a simple procedure. You go to the opposite side, so through the median septum, and fix it there. But the condition for this is that the cord should be of sufficient length to reach to the opposite scrotal sac. In cases where the cord may be too short, but then you can fix both the testes from here, from the scrotal neck, in the same scrotum also.
Same side.
But yes. But for most of the situation, this has to go across the median septum to the opposite side. And this is the algorithm for this. If you assess the cord structures, like the vas and the vessels and the length, if it is adequate, then you go to the opposite side. And if the cord of one of the coming from the opposite side is insufficient, then you may fix in the same scrotal sac. And if it is inadequate, and you may make some little bit mobilization and take it to the opposite side, as in cases of
adequate.
Yes. So next question, what is the trap testis?
Trap testis usually refers to testicular retraction or secondary cryptorchidism after the any inguinal hernia surgery or inguinoscrotal surgery, and it may be due to the postoperative scarring or either any primary maldescent.
So this is about the trap testis. So do we have, Dr. Chinu, do you have any experience about this trap testis? Dr. Arya, Dr. Gyanendra, do you have any experience about this trap testis?
No, sir.
Sir, most of the time, sir, I have seen when during hernia repair, the testis was not reposited into scrotum. It was left, pulled up, and there it got fixed.
Okay.
Yeah, I have seen two, similar to what Dr. Mukesh has mentioned, prior hernia, but testis gets pulled up. But because the cord length is sufficient, it's possible to reposition into the scrotum.
Yes, I agree. Yes. Dr. Pankaj is back, or I think he had a friend because he wanted to see him.
I'm sorry, I was at the phone. What's
Yes, Dr. Chiru, I just asking, do you have any experience about this trapped testis?
trapped testis? That one
Yes,
is
trapped.
retracted.
Yes.
No, really didn't.
Because sometimes it is also given as a short note in the exam also. Yes.
Right.
Oh, yes. So we move to the case. Which child would you evaluate for possibility of disordered sexual development? Part of it has been discussed previously, where we have displayed some of the interesting pictures given by Dr. Bhatt also. And this is the algorithm, which is conditions where you may suspect this DSDs in various situations. Just to recapitulate this, and this is the algorithm available in most of the textbook, and this has been taken from the Campbell. So which DSD might classically present with the unilateral undescended testis?
We have a persistent Mullerian duct syndrome in which we can have unilateral UDT, and we have in mixed gonadal dysgenesis also we can have unilateral cryptorchidism.
Yes. Okay. So these are the two conditions which may be associated with this unilateral undescended testis, like the Turner syndrome or the persistent Mullerian duct syndrome, which may even with that is why it was discussed initially that it is not necessary to have, in cases of bilateral undescended testis, the suspicion of DSD. Sometimes unilateral DSD may also be unilateral undescended testis may also be associated with DSDs also. So what is the workup condition in this situation? And this is the standard protocol which is followed.
We look for gonads. If they're not palpable, then we look for the Mullerian structures, whether they are present or not. We also look for, if they are present, we look for the 17-hydroxyprogesterone, and then we'll do a karyotyping depend on this algorithm, sir.
So, okay, so we quickly pass on this. What are the different syndromic conditions associated with undescended testis?
There are a lot of conditions, especially like Klinefelter syndrome. We have Dennis-Brash syndrome, Wager syndrome. We have Down syndrome. We have Noonan syndrome with hypogonadotropic hypogonadism, like we have Kallman syndrome. In case of hypergonadotropic hypogonadism, we can have this Noonan syndrome and Down syndrome.
Okay.
So there are a lot of.
There is a long list of, as a this trainees, you have to remember at least 5, so that if this is asked in the exam, that can be done.
Yes,
so these are some of the syndromes. Yes. So coming to the last segment of this undescended testis, and this will be with Dr. Sumit. Sumit, are you there? Dr. Sumit?
Yes, sir, he's there. He's there.
Okay. So the first question for you is, what is the role of endocrine therapy in non-palpable testis? What is the rationale and outcome?
Navneet, can you unmute him?
Sumit, please unmute. And Dr. Venkatesh, Dr. Arya, and Dr. Gyanendra are the 2 experts. And anybody can ask questions from the list of experts, right from.
Hello, sir.
Yes, Sumit. Yes.
Yes, I'm there, sir.
What is the role of endocrine therapy in this undescended testis? What is the rationale and outcome?
So endocrine therapy, as of now, as of the current existing guidelines, there is no guidelines stating that endocrine therapy is helpful, because it has been tried in different combinations, and it had been found that endocrine therapy ultimately, as of none of the guidelines recommend endocrine therapy. They have tried to look with LHRH agonist, and they have also tried to look with the HCG also. And the rationale, the main purpose was to induce a testicular descent or to improve the fertility. So for induction of testicular descent, not much benefit has been seen, and that's why none of the guidelines recommend it. Whereas in for the second part, the fertility aspect, a couple of studies show that there is an improvement in the spermatogenic parameters. However, only it serves as an adjunct, and if it is done in less than 1 to 2 years of age, then only it is helpful.
So these are the recommendations, that there is no consensus on the use of hormonal treatment. And in cases of both, whether it is unilateral, bilateral, the evidence itself is very weak regarding the use of endocrine therapy.
Any role in retractile testis?
Hormone therapy, no, sir.
Suppose at the age of 6 years, there is a patient with a retractile testis. Do you consider hormone any benefit here?
So at least EU guidelines specifically say that not to give any hormonal therapy, even in case of retractile testis also. So not so, I would say.
Dr. Shiro, you practice a hormonal treatment in patients with
we are starting to evaluate the idea of doing a HCG treatment after orchiopexy, because apparently there are some studies that show, so especially studies in the north of Europe, that shows that there are some benefit regarding the growth of the testicle after the orchiopexy. So the hormonal therapy alone doesn't have any benefit, but hormonal therapy after the operation might have some benefit. Actually, there is no study yet that they also demonstrate that there is some benefit in terms of fertility, because you will have to do a spermiogram of all patients at puberty and stuff. But for now, there are some studies that are coming up from the Northern Europe population that says that there is actually a real benefit of using HCG after the operation in terms of testicular growth.
So how long you are using, Dr. Shiro, for hormone?
Like an average, it's a month.
Okay. So various products have been used, right from HCG to this gonadotropin also, and depending on dose and the durations, there is no statistically difference have been seen. Some people have given for 4 weeks, some have given to 3 weeks, some 5 weeks also. And this is the combination of HCG or this gonadotropin also, and literature did not show any statistically different in terms of the outcome of this, whether HCG or LHRS have been used, or combination of both HCG and HMG. And there are some literature, as I initially mentioned, instead of advising this hormonal therapy for undescended testis, some literature has suggested that this might improve. Gonadotropins have been used in cases of undescended testis, with an idea that this may improve the quality of the sperms while improving this growth of spermatocytes. So that is one indications where the authors have used as hormonal therapy for improving fertility rather than undescended testis. So what are the different ways to gain extra length of the cord during orchiopexy in open surgery or laparoscopic orchiopexy?
So for open surgery, I'm presuming that since we are talking of extra length, so we have already done an inguinal dissection and we are not able to gain an extra length. So subsequently, what we should do is, if usually there is an associated processus vaginalis, so we need to dissect it until the deep inguinal ring and then ligate it there. That lifts off the vas and the vessels apart from the sac. Apart from that, there are some lateral attachments also, the lateral fibrous or facial bands, which needs to be excised or incised, and often the incision requires a cranial extension, and cranial retroperitoneal dissection is also required. And even after all these things, if it is not sufficient, then what we next do is the Prentice maneuver. In the Prentice maneuver, the testis and the testis with the sublying vessel is bypassed medial to the inferior epigastric vessels, thereby creating a more straighter route rather than an oblique route. And if at all anything does not work, then two-stage procedure should be done. Sir.
Yes, you rightly described, because these are the some various maneuvers which have been described in the literature also. But obviously, you have to make some proximal dissection carefully to get the maximum length possible into the retroperitoneum. If that doesn't work, then you may try the Prentice maneuver, where you take this testicle, the cord structures medial to this inferior epigastric complex. And classically, this has been described in terms of division of this inferior epigastric, but modifications have been done where we do not divide this, and you just make a hole and bring medial to this to get an extra length. While in yes. And in cases of laparoscopy, obviously, if you have some problem in the length of the cord, you may go for the two-stage. But there is one interesting heart attraction technique also, where you dissect the cord and you fix the testis to the opposite this pubic tubercle, 1 centimeter above and medial to that. So over a period of time, 3 to 6 months, due to the attractions of intra-abdominal pressure, it is supposed that the length will increase and you go for the stage orchiopexy in the next go.
Actually, just did the Seata technique a month ago. So soon I'm gonna let you know if it works.
Yes, please. Yes.
It was a Curarino syndrome, so it was a patient who has like both, in addition, both intra-abdominal testicles, and that's going to be interesting to see. Do you usually reoperate the patient how many weeks later? Is it like a month and a half, 2 months? How long do you wait?
Oh, yes, is it 3 to 6 months? 3 to 6 months.
3 to 6 months. Okay.
Yes. Yes. Dr. Arya, Dr. Gyanendra, you want to have some other
if I can,
about this?
May I ask a question?
Yes.
Hello? Yeah.
Yes,
does anyone do a anastomosis within a vascular anastomosis with the inferior epigastric vessels? Does he
we have never this, or this is a microvascular auto transplantation. Never.
So you do
never tried it. Yes.
Never tried.
So, Dr. Siru, in your experience, any microvascular anastomosis to inferior epigastric?
In my experience, so we did, when I was still working in Italy, we did 2 cases, and they actually work well, but we didn't do the entire thing. We just did the venous anastomosis. We didn't do the arterial anastomosis, because the testicle is supposed to have a vascularization through the deferens, through vas deferens, an arterial vascularization. Apparently, what really doesn't, what really helps is to do a venous anastomosis, and actually work well.
Okay.
We did just the venous, we used just the inferior venous epigastric.
Okay. So we did not attempt the arterial one. So we move to the next question. We will just quickly pass. These are some interesting questions, clinical questions. So these are some photographs of diagnostic laparoscopy. And Sumit, you have to just tell the findings of the image 1, 2, 3.
Yes, sir. Sir, in the first image, I can see that the vas deferens and the spermatic vessel are exiting the internal inguinal ring, which is closed. And in the second image also, I see that the right side vas and the right side vessels are exiting the ring, but then here the ring is open. So probably associated with the patent process of vaginalis also. And in the third image, I can see that the vessels are blind ending, and the internal ring is closed, and vas is almost reaching, but not clearly appreciable whether it's reaching the internal ring or not. So in these first two conditions are basically almost similar in terms of management. We need to do a further inguinal exploration because we can clearly see that testicular vessels are exiting the internal ring. Whereas in the last image, we can see that the vessels are blind ending, which in other way is suggesting that it probably is a vanishing testis syndrome kind of picture. So we abandon the procedure, and that is where we
So
ended.
what do you call this third situation?
Vanishing testis.
Yes.
Blind
So
ending vessels.
Yes, you do not explore the inguinal canal.
We do not. Yes. Yes.
In this condition,
this is just a testis which is there at the internal ring, almost at the internal ring. So, and you are holding a structure to pull it out from the internal ring to see. So it is almost like a peeping testis, sir. So, and it is, since it is very near to the internal ring, then it can be explored internally and taken down, sir.
So this is the case where one stage. This even with the inguinal exploration, this can be done.
Yes, sir, yes, it looks like that, sir. Hopeful.
Okay. This.
Vas is seen and the testis is seen. There is a certain amount of distance. I don't know exactly how much, but what the second arrow is trying to point out is not very clear in the picture. But I can see that the vas is trying to reach the testis.
This is the vas. This is the vas.
Yes.
And these are the iliac vessels.
Is there a discontinuity in the vas?
This is the testis. This is the testis. And
yes,
this is the
internal ring.
Yes. What will you do?
Sir, here also I'll assess with the laparoscopic instruments whether how long is this. If it is more than 2 centimeters, then I will straight away not do any further dissection and do a staged follow-step surgery.
So this is clearly visible. Any testis is lying along the iliac vessels. This has to be high in this testis. And whether you measure it or not. See, it is lying almost here, the iliac, even away from that. This is much higher. So this has to go for the stage. Okay. Since we are running already late by almost 30 minutes, so we can quickly pass some of the questions and come to the clinical questions. How do you follow a child after orchiopexy?
So the child initially should be followed up at around 6 months of age, and then eventually after that he should be followed until puberty annually with an ultrasound of the scrotum.
Okay, so just to quickly, for the sake of other PGs, a minimum of 6 months of follow-up is recommended to determine the posterior testis position and the size. Boys after orchiopexy need ultrasonography evaluated every 12 months, and long-term follow-up should be considered for counseling of the patients regarding the fertility issues, risk of testicular malignancy, and self-examination. And the self-examination has to be done monthly by the parents, or if the child is grown up, he can do himself. So coming to the next question, how long should you follow a child with retractile testis who has been managed conservatively? And you have to tell the fate of this retractile testis also. If you see 100 children of retractile testis, what will happen?
Sir, retractile testis are also followed up in a similar pattern, sir. They are followed up annual basis until puberty, and these patients usually they do better with respect to other undescended counterpart.
Well, you did not tell if you follow the 100 cases, what will happen?
Okay.
Some will fail, some should fail.
Some, I'm not sure about the data. I would not estimate.
Some should fail.
Some.
And what is the number? Out of 100, how many will fail? It is not that 100% of retractile testis will settle with follow-up. So 15% will remain retractile. Then you have to fix it, and you have to follow it by puberty. Yes.
Yes.
So we can skip this part. So this was the last
One question, sir.
Yes.
Can I ask a question, sir?
Please go ahead.
Yeah. When would one do an orchidectomy rather than an orchiopexy in a child who has presented with undescended testis?
Yes.
A few scenarios that come quickly into my mind are if the child is already presented with a complication of the undescended testis, like already tauted testis or a testis with a tumor, number one. Number two, when the child is presenting at a very late age after puberty, then there is no point in preserving because all functions are already gone. These are the two scenarios when orchidectomy will be upfront my choice.
So gonadectomy is, that also depends on the age of the child. In post-pubertal, if it is a unilateral, and if it is an atrophic testis, obviously you will remove it. You will not try to preserve it. Yes.
Atrophic unilateral, yes.
Yes. And secondly, in gonadectomy is also recommended in mixed gonadal dysgenesis when you are having a DSD also, where certain DSDs, they have a potential for a higher malignancy, gonadoblastoma also. These are the kids, they should also be subjected to gonadectomy. Yes. So, but sir, so after a long journey, we have come to this phase of our meeting.
I think this has been an excellent program, though we have switched a bit late. We asked excuse from the USI, but the things were very good. We had a very good discussion, and there were a good number of participants. One time it shooted 60. And I must thank you and thank all the participants who have joined and participated, and all the experts, and especially Zero and Pankaj, who has spared the time for this one. Thank you very much.
Thank you.
Yes, sir. Any other expert, sir? Any other expert?
Sir, I want to ask one last question, if you allow.
Sir, please go. This is, sir, the time of question and answer has gone, Dr. Bhatt has said.
Sir, any time you operate the retractile testis, do you believe that retractile testis can lead to the reduction in the volume? So there can be a time to operate the retractile testis. Do you consider any time this?
Yes, Dr. Chiru, will you take this question?
Yeah. I usually consider by the age of 4, if they keep growing and they still have a retractile testis, I do surgery on them for 2 reasons. Actually, there is some evidence that if you don't operate on them, there is a risk of reduced growth of their testicles, and yeah, that's basically it. I give myself like until the age of 4. What about you?
Yes, yes.
Go ahead, sir.
Go ahead. Yes, go ahead, please.
I generally wait till 5 to 6 years. This is just a time when I take a call because I agree with him that there is a reduction, some reduction in the testicular volume. And I have seen surprisingly by that time, by that age, sometime they come comfortably into the scrotum. So there is no such fixed answer with me. That's why I raised this question.
Definitely before puberty, yeah, that's for sure.
But it does reduce the testicular volume if it stays for very long. Retractile testis.
Yes, this is reduction in the volume is one of the indication of intervention, early intervention. Then you need not to go until puberty. That is point well taken. Yes. So, Dr. Gyanendra, Dr. Mukesh, any comment from your side?
Nothing, sir. Had an excellent session. Really loved it. Every aspect of undescended testis has been discussed in detail. I think it's available on the net for students for years together to be listened, and possibly everybody would want this case in their exam.
Yes.
Fabulous session.
That was the basic objective, because they should be useful for those who are trainees, and this may at least solve both the problems, the ward round as well as some questions which are usually asked in theory examinations. There are 2-3 questions because the time was short, we just skipped it. But I think maybe if we have another round sometimes later, we can cover those questions also. Otherwise, most of the information is available in most of the student textbook. But there were some tricky situations which are only available that usually comes through the experience of great surgeons and like you all, and which you have given. So, Dr. Pankaj, are you back? He's still logged in, but he had a friend, I think, because he might be entertaining that. So let me thank now on this occasion and Dr. Chiru, Dr. Pankaj for giving their valuable time. Since Dr. Pankaj is visiting India, so he will also be with us on Monday as well. And Dr. Chiru, it was really for you giving an extra time for us during your duty hours. You were on call today. So you are sick in your...
That's fine. Oh, hopefully it's going to keep like that and not going to have too many calls. But thank you so much, Dr. Ansari, for organizing.
This is almost, we have consumed almost 3 hours from you today.
You know what? It went well. It went so smooth that we didn't feel it. It was so interesting, was so well organized that I actually enjoyed. I didn't feel the 3 hours. Actually, I could keep going if you want. So it's not a problem.
So
it was very well organized. Thank you. It was nice meeting you all. And it was really very organic. I want to thank you for all this, for inviting me.
Thank you, Dr. Siro. And I also thank Dr. Amil Albert, Dr. Chandra Singh, Dr. Malika Arjun. I think he was busy in OR, could not come. Dr. Takwani, Dr. Prasanna, Dr. Hemant Pathak, Dr. Uday, Dr. Venkatesh Kuls also could not make to join, but Dr. Mukesh Arya and Dr. Gyanand Sharma were throughout us to enlighten all of us as well as the trainees. And of course, the last I cannot forget, Dr. Priyank, my this colleague. And Priyank, where are you?
Yes, sir, I am.
I just saw your bright face. And Shiro, he has been a sick kid for 2 years there in Toronto.
In Toronto, yeah. Yes. I think we met each other. Yes,
yes.
Now I see
met
you.
In Belgium. Yes.
So Priyank remembers you a lot, Shiro.
We had a great conversation in that the cycling velodrome with Dr. Mahen Gundeti.
So for me, most of the time is my Sankat Mochak, and he has been a great help throughout the preparation of this. And my special thank to Dr. Anvesa. Where are you? You're always hiding behind. Just put all the participants. They should put their videos on. Dr. Anvesa, Dr. Anil Bey, Dr. Anupam Shukla, Dr. Himanshu, Dr. Sumit. Yes, Sumit has come. Anil has come.
Sir, maybe if you take off your slide, Dr. Ansari, your slide is still on display.
Oh, on the display?
Yes, sir.
Yeah.
I will just stop sharing.
Sorry, my camera is not working. Wonderful.
Yeah. Now it is?
Yes. Wonderful.
Yes. So this is our team, sir. Sumit, Dr. Anvesa, and Anil Ved and Abhishek.
Yes, sir.
Yes, Anil Ved. Where are the others? Where is Anupam?
Himanshu, sir.
Yes, Himanshu. Yes, good. So I thank you all. Really, this had not been possible without the help you all. And this was really a great session. As you have seen, lot of applauses and everything goes to you. And of course, we seek blessing from Dr. Bhatt to declare his close now.
Okay, thank you.
Thank you.
Let us close it. Thank you.
Thank you. Hope to see you soon.
So
thank you.
Thank you so much. Thank you, Dr. Siro. Dr. Prasanna, are you there?
Yes, sir, I'm there.
So
Yes,
please,
sir.
please show your shining face to all of us, sir.
Shining
We were just
face.
looking high. Oh my God.
Hi, sir.
Thank you so much.
Wonderful, sir. Wonderful session. Excellent. Very much in detail. Thank you, sir. Thank you.
Thank you so much. So now we disperse with the permission of Dr. Bhatt and other colleagues. Thank you so much, everybody. Thank you so much.
Thank you to entire team of Dr. Ansari and SCPGI. Priyank.
Yes.
For strong and excellent program. Thank you very much.
Thank you very much.
Thank you.
Thank you, sir. Thank you.
Bye.
Thank you, sir.